started. Thank you all for joining the SWOG virtual fall meeting. This is the Lung Committee main meeting session. Let's see here. We have just a great session for you guys today. Here are my disclosures. Here is the overall agenda update. I do want to begin by welcoming our new members. And here they are, Dr. Dwight Owens from the Ohio State, Dr. Henry Park from Yale, Dr. Rolfo from the Mount Sinai, Dr. Cerlansis from Medical Oncology Cardinal Bernardin Cancer Center, and Dr. Porter from Medical Oncology West Cancer Center, Germantown, Tennessee. I do want to remind everybody that if you have a question, please use the chat function. And for those of you that are panelists, you can either raise your hand or just speak out. That would be great. I'll still try to work on my technical difficulties as we go along here. Okay, so next slide. So here I always begin with this slide. This is a snapshot of the portfolio across the NCTN. As you can see, there's a lot going on in the world of lung cancer. As everybody knows, it really is an exciting time. We're making so much progress. What you see here in the dark blue are SWOG trials, and you'll hear more about this since our last meeting. We did just activate in September the Nrg Trial. So you'll hear about that in a minute. We also, in the gray, are our collaborations with our other NCTN partners here. And I do just want to point out that this Alliance trial, which is a first-line study in patients with PD-L1 zeros, it's a randomization between IO-based regimens, that's with chemo, without chemo, and plus or minus SBRT, and that is scheduled to open in November of this year. So I just wanted to point that out as well. And I'm also very pleased to report that we have increased our accrual. You can see here from July 2020 to June 2021, even though we're still in the COVID era, we've really done a great job of increasing accrual. So I do want to say to everyone out there, to all the investigators and members, thank you so much. You know, it's just so important. We have all these great SWOG trials and great trials across the whole NCTN, and the best way to move the field forward is to accrue them as quickly as possible and help our patients. So again, I just want to say thank you so much, and this is just fantastic. I suspect we'll be hitting these 2016-17 numbers here shortly. So this is fabulous news, and again, it does take all of us to do this. So just reiterating my huge thanks. All right, in terms of publications, since our last meeting, we've had 6 publications, and you'll hear more about a couple of them later on, but I just want to point that out, and that we continue to work very hard. We've got a lot of things going on in terms of manuscripts, not only on the actual clinical data, but also on the translational medicine side as well, with data there. So I'm very pleased that we're working hard on all fronts to help our patients with lung cancer. And with that, I'm going to turn it over now to Judy Johnson, our magnificent patient advocate. Judy.
Hi, everybody. Thanks, Karen. For those of you who already heard me give this talk the other day, I will be shortening it a bit, so no worries. Next slide.
Okay, yes, there you go.
Okay, so here are the things that myself and my colleague patient advocates think about when a new concept is presented. Most of you have already heard this, but I think it's important enough to go over it briefly again. But the key message, as you can see from every one of the bullet points on the slide, are that they are completely patient-focused. Nothing that we do as advocates in the patient advocate committee involves anything but the patients. And all of these items are things that we look at whenever there's a new concept. And if patients aren't interested, or if they're not able to participate, there is no study. So if we don't look at these items, we're missing the boat for sure. Next slide, please. Can you go to the next one? There you go. Okay, good. So I want to just make sure everyone's aware that we also, besides research advocates like myself, have a group of community advocates that focus on the areas that you see on this slide. And it's really important because community hospitals recruit a large percentage of SWOG trial participants. This group of community advocates can enhance the concept design and review process. They can give feedback on how a concept could impact those communities that they represent. So what better way to identify real world needs than by collaborating with advocates within these communities?
Sorry, it's
Okay.
it looks like it's taking a little
No problem.
delay
No problem.
there.
Thanks. So this is a summary of the differences between research advocates and community advocates. The key message, though, is that research advocates like me are embedded in one committee, helping with any trial that the committee develops, implements, and manages. The community advocates can be called upon to work on a project or offer advice for any committee on an ad hoc basis. They may work with several committees.
Okay.
So there. Oh, good. Thank you. That's the slide I need. So moving forward, as we continue our work, these are the items that I am really committed to doing with all of you. The community advocates will become more involved in helping us design trials that matter to patients. And for every new concept, I will be recruiting one or more community advocates to work with me and all of you so that we can incorporate their perspective. Clinical trials are starting to implement ASCO and the Friends of Cancer Research guidelines to broaden eligibility. We've been doing this gradually in our lung studies, happily. And in this way, we'll offer trials to patients who represent the real world, and results will apply to more people. COVID-19 pushed NCI and NCTN groups to adapt quickly to support patients in trials and helped to continue accrual. We all need to take responsibility for maintaining these improvements, pushing for them, and pushing hard. Things like increased telemedicine visits, getting oral therapy drugs in the hands of patients in their homes, enabling them to go to get labs at local sites, and using remote consent as needed. Patient-reported outcomes highlight the study participants' experience and feed into the study design evolution. So it's important that we include these in treatment trials when we can, in collaboration with SWOG's PRO core group. And last but not least, as the biology and subtypes of small cell lung cancer become more defined, we have the opportunity to develop studies for these patients. They need more options, and perhaps we can provide them. Last slide. I want to thank each and every one of you for all that you do to help lung cancer patients and for collaborating with me from start to finish. So I'm looking forward to keeping up collaborating with you and really appreciate your time. Enjoy the rest of the meeting. Thanks.
Thank you, Judy, as always.
You're welcome.
Make some really great points. And we are so appreciative of all the work that you do for our committee and for the patients. Okay, there seems to be a little delay in when I click the button and the slide moving. So just FYI. All right, so I'm really pleased that this year the Lung Committee is hosting the Robert B. Livingston Translational Breast and Lung Cancer Lectureship. Dr. Livingston was an exceptional and passionate clinician, investigator, and mentor. He really was only one of a handful of our colleagues that can really do exceptional work in both breast cancer and lung cancer. He was the chair of our lung committee from 1974 until 1997. Just really shows you the commitment that he has to the lung committee. And then he chaired the breast cancer committee from 2000 to 2008. You know, I am certainly deeply indebted to Dr. Livingston because he gave me my first opportunity to chair a trial in SWOG. And I know many of you know Dr. Livingston and hold him in such high regard as I do. I am also incredibly pleased to announce the recipient of this lectureship this year to Dr. Valerie Roosh. Dr. Roosh is a thoracic surgeon at Memorial Sloan Kettering Cancer Center. She is the minor family chair in intrathoracic cancers, the vice chair for clinical research in the Department of Surgery, and the immediate past president of the American College of Surgeons. Throughout her distinguished career, she has played an instrumental role in the surgical advances for thoracic malignancies, the promotion of multidisciplinary collaborations, and has paved the way for women to pursue a career in thoracic surgery. So we applaud all of the work that she has done in the past, as well as all of the work that she continues to do today. So she's going to share with us her perspective on advances in lung cancer care. Now, this is going to be a pre-recorded presentation, but Dr. Roosh will be available after the presentation for a short Q&A. So with this, I hope this works. So I'm going to try it.
Good afternoon, and thank you for the privilege of giving the Robert Livingston Lectureship on Advances in Lung Cancer Care, Perspectives from a Surgeon. Here are my disclosures. The only relevant one is that I serve on the steering committee for the LCMC3 trial, which is supported by Genentech, and which I will mention during this presentation. The opportunity to give the Livingston Lectureship is an honor, but also one with personal meaning. In the early part of my career, when I was a faculty member in the Department of Surgery at the University of Washington, Bob became my mentor in thoracic oncology. He provided an introduction and an entree to the cooperative groups, particularly the Lung Cancer Study Group and SWOG. He taught me a lot about the design and conduct of clinical trials and was very supportive of multidisciplinary care and of the involvement of surgeons in the SWOG Lung Committee. I thought that today would be an opportunity to comment on multimodality therapy in non-small cell lung cancer, particularly in locally advanced disease, to provide a brief historical perspective, to discuss some aspects of recent neoadjuvant therapy trials, and to reflect on potential future directions. I suspect that most of us here today can recall that for at least 2 decades, multimodality therapy options for locally advanced non-small cell lung cancer were relatively stagnant. We had little insight into tumor biology and a limited, relatively toxic repertoire of systemic agents. Only after many challenging and somewhat lackluster clinical trials was the LACE meta-analysis able to demonstrate an absolute 5% overall survival advantage at 5 years for adjuvant platinum-based chemotherapy following complete surgical resection. Benefits of similar chemotherapy regimens in the neoadjuvant setting yielded modest improvements as well. The watershed moment came in 2003-2004 with the discovery of EGFR mutations and deletions and their pivotal importance in conferring sensitivity to the first-generation tyrosine kinase inhibitor gefitinib. Never before had we seen patients with metastatic lung adenocarcinoma experience such extreme and rapid disease response, as you can see here in a patient whose primary tumor in the left lower lobe was no longer visible after 3 weeks of therapy and who remained in remission more than a year later. Starting with an astute observation by medical oncologists involved in this trial that a small proportion of patients experienced such dramatic responses, the subsequent identification of the biological basis for this response represents a terrific example of bench-to-bedside translational research. From that time to today, there has been a revolution in our understanding of lung cancer, particularly adenocarcinoma tumor biology, taking us from only KRAS being known in 1999 to the discovery of EGFR mutations in 2004, to the identification of many less common but important driver mutations during the ensuing decade. These biological discoveries and the rapid development of many novel therapies to target specific driver mutations took us from the fantasy of a New Yorker cartoon in 2005 to the reality of being able to use many of these targeted therapies in daily clinical practice, all within the space of about 7 years. As everyone in this audience is well aware, the extraordinarily rapid development and subsequent FDA approval of many targeted therapies and the much more recent advent of immune checkpoint inhibitors have completely transformed the treatment of patients with advanced non-small cell lung cancer. The success of IO in advanced disease, of course, led to the landmark PACIFIC trial demonstrating the benefit of durvalumab after definitive chemo-RT for locally advanced, unresectable non-small cell lung cancer. However, the application of these advances to patients with resectable, locally advanced lung cancers has been much slower, and it was not until this past year that, as a first step in this direction, the ADAURA study showed the benefit of adjuvant osimertinib after resection of EGFR mutant lung cancers. Along with 2 previously reported small phase 2 trials of preoperative gefitinib, the success of the ADAURA study provided the rationale for the ongoing Neoadjuvant trial. Enthusiasm for testing immune checkpoint inhibitors in the neoadjuvant setting was in part prompted by this small 2-institution phase 2 trial using 2 cycles of preoperative nivolumab in patients with resectable stages 1 to 3A non-small cell lung cancer. Briefly, this study showed low toxicity for this approach, no delays to surgery, and a remarkable 43% major pathologic response rate. In turn, the success of the nivolumab trial provided the rationale for the LCMC3 trial, the schema of which is shown here. And this trial tested the use of 2 cycles of atezolizumab followed by surgical resection in patients with stages 1B to selected 3B non-small cell lung cancer. This is the largest multi-center trial of neoadjuvant IO and surgical resection performed to date. This study, which has been presented but not yet published, met its primary endpoint with a major pathologic response rate of 21% in the primary efficacy population, specifically those patients whose tumors did not harbor EGFR mutations or ALK translocations. Similar to what was seen in the nivolumab trial, toxicity was modest and patients were able to undergo surgical resection within a much shorter window than is typical for neoadjuvant chemotherapy. As seen in the middle figure here, most patients had a lobectomy and more than 90% had an R0 resection, shown in the right-hand figure, a result that compares very favorably to previous neoadjuvant trials of similar design listed in the table, these trials using preoperative chemotherapy. Interestingly, more than half of all patients had a resection via a minimally invasive approach, as you can see on the left, either by VATS or robotically assisted VATS. Other remarkable results have been reported for a phase 2 multi-center trial in Spain of chemo-IO followed by resection in 46 patients with stage 3A non-small cell lung cancer. This approach was associated with a 91% resection rate, a 74% MPR rate, and a 57% pathologic complete response. In an update this year, overall survival was 82% at 3 years. The response was noted to occur irrespective of tumor mutational burden and PD-L1 status, and ctDNA clearance appeared promising as a biomarker of response. With a half-dozen large randomized clinical trials now testing the efficacy of neoadjuvant chemo-IO followed by surgery in locally advanced resectable non-small cell lung cancer, the first trial to report out is the Checkmate 816 trial, comparing neoadjuvant platinum-based chemotherapy plus nivolumab to chemotherapy alone. The very compelling results presented at ASCO this year show a far greater depth of response in the chemo-IO arm of the study, as assessed both by major and complete pathologic response. An interesting and provocative finding was reported in terms of the surgical management of these patients. The chemo-IO arm of the study was associated with a lower frequency of pneumonectomies and a greater rate of complete resection, perhaps because of the deeper degree of pathologic response seen in these patients' tumors. It will be important to see if other ongoing trials of this design corroborate these compelling clinical results. During this period of remarkable transformation in our understanding of non-small cell lung cancer tumor biology and advances in systemic therapies, surgical management has also evolved substantially in ways that affect multimodality therapy. Improved, less invasive staging methods, specifically endobronchial ultrasound and esophageal ultrasound, have largely replaced mediastinoscopy and have extended our ability to biopsy some nodal stations actually not accessible by mediastinoscopy. We have developed a better understanding of the factors dictating the risk of pulmonary resection, particularly the percent predicted diffusion capacity. There has been a steady decrease in the use of pneumonectomy, both because of a shift in the epidemiology of non-small cell lung cancer and also because of improved understanding of lung conservation whenever possible, sometimes through the use of sleeve resections. Also, across the world, thoracic surgeons have substantially shifted to minimally invasive techniques for lung resection, either VATS or robotic VATS. Consequently, there's been a very substantial decrease in morbidity, mortality, and costs, along with an improved quality of life associated with pulmonary resections. The importance of the shift to VATS has now been definitively shown by the Violet trial, also reported at ASCO this year. This randomized clinical trial performed in the UK randomized 503 patients with early-stage non-small cell lung cancer to either open or VATS lobectomy. Early in-hospital outcomes reported in 2019 were confirmed in this analysis of definitive primary and secondary study outcomes at 1 year. Briefly, VATS lobectomy was associated with less pain, fewer complications, shorter length of hospital stay. Physical function and quality of life were superior, and oncologic outcomes were the same at 1 year. The Violet study confirms the importance of the global paradigm shift in surgical approach for early-stage non-small cell lung cancer that has gradually occurred during the past 2 decades. It definitively provides evidence that VATS lobectomy yields superior surgical outcomes without compromising oncologic outcomes, and it also includes endpoints that are highly meaningful both to patients and to healthcare systems. Perhaps the greatest current controversy within the thoracic surgical community is whether robotically assisted VATS provides a measurable advantage over standard VATS. Many surgeons feel that robotic approaches are technically and ergonomically easier because of better illumination and magnification, as well as three-dimensional views and the wristed motion of the instrumentation. No definitive evidence yet exists in the published literature. Some studies, such as this propensity score matched analysis of the large US-based Premier healthcare database, compared VATS to robotic lobectomies in more than 1,600 patients. In addition to many studies that have shown that robotic procedures provide a more extensive lymphadenectomy, this study, as shown here, demonstrated that robotic VATS was associated with fewer complications. The now extremely low mortality of around 1% for either of these approaches has been reported in other large data sets and has important implications for multimodality therapy. Additional studies, such as this single institution analysis from Ohio State, have shown the importance of evaluating all aspects of the associated costs for these various surgical approaches. As seen here, the higher OR equipment costs for robotic approaches may be counterbalanced by higher postoperative costs related to hospital length of stay for other approaches. These data illustrate the complexities of studying differences in surgical approaches, which in turn can also affect the results of multimodality therapy. Thus, as thoracic surgeons, we will need to continue to evaluate rigorously these various surgical approaches in terms of outcomes and costs. Importantly, we will need to determine whether robotic approaches allow the extension of minimally invasive surgical techniques to more patients with locally advanced non-small cell lung cancer receiving neoadjuvant therapy. And we will need to determine whether these techniques will accelerate recovery and facilitate adjuvant therapy. In designing clinical trials and integrating surgical care into multimodality therapy, it is important for all of us, surgeons and medical and radiation oncologists, to understand that different neoadjuvant therapies carry different implications for surgical and perioperative care. Toxicities differ, of course, depending on whether neoadjuvant therapy is platinum-based chemotherapy versus chemo-RT versus IO or chemo-IO. The window to surgery can be very much shorter if the neoadjuvant therapy is a TKI or an IO monotherapy, and the ways in which we care for patients perioperatively can differ substantially. Thus, looking to the future, I think that it will be key for us to refine patient selection for multimodality therapy, partly through a much broader use of NGS testing in the surgical patient population. While this is obviously standard care for patients with advanced disease, it still happens to a very limited degree in patients with resectable non-small cell lung cancer, and only a small number of institutions, such as my own, do such extensive genomic testing in this surgical patient population. We need to be mindful of the fact that within the multimodality setting, more therapy is not always better therapy. Clearly, at least 20% of patients with locally advanced disease whose tumors do not contain driver mutations respond very well to low toxicity IO monotherapy. Our job is to understand better how to identify those patients and how to avoid more toxic therapy. We have tended to accept an attrition rate during neoadjuvant therapy either from lack of response or deterioration in performance status. We need to focus on how to decrease both of these risks. We need to be able to define response to therapy or need for further therapy better. Serial ctDNA holds some promise in this regard, but its value needs to be determined and confirmed, and potentially other parameters considered. We need to include a rigorous assessment of surgical methods and approaches in our trials because it can affect the success of therapy and its impact on patient well-being. With now clearly improving therapies, it's important not to lose sight of what I call the big picture and to measure the impact of what we do on healthcare costs and patient quality of life. Thank you for your attention.
You're muted, Karen.
So thank you, Dr. Roosh. We really appreciated that fantastic talk. I know that you're here, and so we'd be happy to take some questions for Dr. Roosh. I'm going to open it up if people have questions for you.
Hi, Valerie. This is Wayne.
Hi, Wayne.
I'm sorry, I walked in a couple seconds late. What was the primary endpoint?
For which?
Rats versus VATS.
That in the Premier, you're talking about the Premier database?
Yes.
Yeah. That's really a comparison of VATS versus robotic VATS in terms of healthcare costs. And not, I don't mean charges, but healthcare costs, which of course, as you know, are very hard to calculate in most hospital settings, particularly for surgical procedures.
So, Valerie, it's Karen. You know, I think you've made some really good points about the fact that, in essence, this is becoming much more complicated in a good way to really learn how and who is the right person for a neoadjuvant approach, an adjuvant approach, both approaches. But how are we going to really, and I'm sure you've thought about this, educate our surgical colleagues in the community, and how are we going to be able to work more closely together, because it really is becoming very complicated.
Yeah, I'm not sure exactly from which perspective you mean that, Karen, but I think certainly from the standpoint of patient selection and extending NGS analysis from the advanced disease population to the surgical patient population, that's something that's obviously everyone on this call understands in a crystal clear manner, but I think that many surgeons in the community are less familiar with that concept and the importance that this plays now in selecting patients for both neoadjuvant and adjuvant therapy. We've been doing MSK Impact on all of our surgical patients for about 7 years now at MSK. And so I think the education really comes through having sessions or discussions at tumor boards. That's a great venue to be talking about these issues. And also the issue of minimally invasive surgery as opposed to open operations. That's also something that can be discussed between oncologists and surgeons. And the final thing I think that surgeons fail to understand is the fact that radiologic response, particularly after chemo-RT or after IO, does not always predict pathologic response. And so they're sometimes making judgment calls about the feasibility of surgery strictly based on imaging. And again, that's something that every medical oncologist, I think, is familiar with, but not all surgeons are familiar with.
So do you think, Valerie, my point was, do you think that when a surgeon sees a patient, that on their checklist, it should say, please see the medical oncologist before going to the operating room? Or is that a culture we should try to instill? Yeah,
I think I think it's obviously not applicable for patients of early stage disease, but for patients who have locally advanced disease, it's incredibly important. And vice versa, of course. I mean, I certainly see patients who have been referred to a medical oncologist by, say, a pulmonary medicine physician, and have not necessarily had appropriate staging or consideration of surgery as part of their care. So it works both ways.
Right. Right. I agree with you. I think the point about educating in a helpful way, of course. I think you mentioned the NGS sequencing, and I think it would be, we need to put our heads together on how we can better work together. Sometimes tumor board isn't always readily available to all the time. And so I think we need to have some other ways to perhaps develop that culture. I don't know, Wayne, if you want to give your thoughts, or if we have other surgeons on the call.
Yeah, thank you for that. I would double down on what Dr. Roosh just said. I think with more of the data coming out on local therapies or local consolidative therapies for locally advanced tumors, 3A, 3B, and even oligometastatic disease, that the role of local consolidation is something that we shouldn't ignore for several reasons. One, because local control is, I think, a great component of the therapy for these patients and is improving overall survival. Two, because it gives us the opportunity to find out exactly what component of these tumors are resistant to the therapy. Needle biopsies and core biopsies can only tell you so much. And if you've started out with some therapy on the front end and have the complete tumor to examine on the back end, we're going to have a much better understanding of what the resistant components of these tumors are, especially if we are removing primaries and mets to evaluate.
Mm-hmm.
So it's an important part of our therapy at MD Anderson. I'm sure they're doing the same thing at Sloan Kettering. And I think that's something that needs to start working its way into the general population.
I'm going to put Ray O on the spot here. What are your thoughts from a community-based perspective?
Oh, absolutely. I will be giving a talk today that actually addresses part of this. So this is perfect setup for me. And I would just say, watch this space in an hour and a half. So bottom line, absolutely, multidisciplinary decision-making saves lives. We've done work to demonstrate the survival value of that. So sans doute, really the challenge then becomes, how do you make it happen in reality? Mm-hmm. Not in name, but in reality, meaning, how do you benchmark it to be able to see it, to recognize it when you see it, and know it when you don't see it? Everybody wants to call their program a multidisciplinary program. And when you look more closely, you find just this wild heterogeneity, sometimes even just, show and tell kinds of things being called multidisciplinary care. But I do have a question for Valerie, for Dr. Roosh. Valerie, enjoyed your talk as always, great talk. Question. So as you may or may not know, we just opened a superior sulcus trial. We call it NASIS. It's an intergroup trial. And it's basically comparing your backbone trimodality approach with the slight modification of all chemotherapy being given upfront rather than a perioperative approach, versus the same thing with the addition of atezolizumab. My question to you is, in your experience, do you think we're going to run into problems since a component of this is concurrent pre-op radiation therapy? Are we likely to see something go off on us, especially in community programs where we think a lot of these patients are going to come from?
Yeah, thanks, Ray. You may. And I think it is actually, first of all, high time to take the SWOG 9416 trial, the one you're alluding to, and apply updated treatment modalities to this patient population. And it's not an easy thing to do because it's very complex surgical management after induction treatment. But it's totally worthwhile, and absolutely, given the promise of chemo IO, I think the addition of that is a terrific a direction for these patients. I do worry. I think that the radiation that has been used now as pretty much standard care for the past couple of decades is terrific in the sense that it usually that regimen gives patients rapid pain relief, but it also can be quite debilitating in terms of esophagitis and general performance status. So if it's a chemo IORT regimen, it'll be interesting to see what the tolerability is.
All right, we have another question for you from Dr. Redmond.
Hi, Valerie. I was wondering if you could talk a little bit about, you said that there are a lot of questions to be answered, but it didn't, I don't know that you necessarily spelled all of them out. I'm wondering how you think we should go about addressing them. It seems like there's going to be a series of studies that address different aspects.
Well, at a minimum, Mary, I think that within the context of multimodality trials that are being done in this country, it's really important to have specific surgical guidelines. That pretty much happens now, but it shouldn't be an afterthought. And at least secondary analyses that look at some of the surgical outcomes that are designed prospectively, so it's not an attempt to do some kind of post hoc analysis. The Violet trial was really overdue, and I think it's a commentary on the healthcare structure in this country that it didn't get done in the U.S. That's not an easy trial to discuss with patients, open versus VATS, and the fact that the UK pulled this off is really, I think, in large measure related not only to highly motivated surgeons and an incredibly good clinical trials leader, who's Eric Lim, but also the fact that they've got a universal healthcare system and some regionalization, systematic regionalization of care, so that that infrastructure really fosters being able to do clinical trials that have ask a difficult question like that.
Yeah. And when it gets to looking at biomarker-defined subgroups and trying to investigate if there are targets and other things, it seems like maybe we need more information. And then, I mean, those are small populations, so that makes it hard.
Yeah. Yeah. So I think I'm less concerned about the targeted therapy trials, which all have a pretty similar structure in the neoadjuvant setting now. But I do think it's really important for us from the toxicity perspective and the patient perspective to kind of ferret out this issue of, do we need chemo IO that has this rather dramatic response, apparently, and deep pathologic response in many patients? Does everyone really need to get that? Because the monotherapy approach is very low toxicity, extremely well tolerated. As I said, short window to surgery, et cetera, et cetera. So I think we need to sort of begin personalizing the approach and not just assuming that the rather dramatic advance that we've seen with chemo IO is the best recipe for every patient.
So Valerie, thank you again so much for the great presentation and for being here and for being the recipient of this wonderful lectureship that has been set up. And we look forward to working with you. I'm sure you have a lot of great ideas and we'd be happy to discuss those with you as well. So thanks again. We're going to move on to our next presentation, and that is on our surgical trials. And Dr. Hofstetter, take it away.
Thank you. Thank you, Valerie. So we have a few trials just for review. Am I in control or is someone else controlling?
I've got control, so
okay.
I'm.
Great. We can go to the next slide. So among the open SWOG participating trials, we've talked many times about the Alchemist Trial. This is for patients who are stage 1B to 3A, typically primarily surgically resected, and patients who have undergone completely resected non-small cell lung cancer are then put into Alchemist. You can go to the next slide. The current schema is that Alchemist is an umbrella trial for several different targeted studies. Most important that I think that we had talked about earlier this week is the fact that although we're screening many, many patients before they get put into the individual trials for targeted therapy, we have almost 6,500 patients who are screened and accrued to the screening portion, which means that there's tissue available on those. And I think that this represents an extraordinarily important subset of patients that can be mined for further information. So I think we'll hear more and more about this group of patients, and that this will become a very important part of the Alchemist trial moving forward. The EGFR inhibitor versus placebo is closed. The ALK inhibitor is a very small subgroup of patients, and we're moving towards closure. We're at 133 out of 166. I expect by the next time it'll be another 20 or so. Maybe by this time next year, the ALK arm will be closed. The Anvil arm closed very rapidly. That was open and closed, I think, within 14 months. And the follow-up to that was AO 81801 with chemo pembro as adjuvant. And the accrual is ongoing with that. And there's a laudable endpoint for sample size at 1,263. So that has been open for, I think, Karen, about a year now. And so we're at about 219 patients.
Yep. So I just wanted to stop and ask if anyone has any issues with this trial in terms of problems putting patients on, barriers putting patients on. And anyone have any comments? Let's see here. So
I'll start it off, and just as people are preparing their questions, I will admit that it was very difficult on our infrastructure to be getting people onto the screening side with the translation into the targeted arms being less than 1 in 10. In fact, I think when we started, it was less than 1 in 20. But as we've moved forward and got more and more patients and seeing what's happening nationally, as I said, I'm extremely excited about that screening arm of the trial and the biorepository that's come along with it.
okay. I'm not seeing any questions here, so looks like people are accruing and trying to find patients for this. This is an important trial. So of course, we will wait to see what happens from the Empower 010 trial and see if that gets FDA approved, and we'll have to make some adjustments, but more to come on that.
Karen, the FDA approval
It
came
was
this
approved
morning.
today.
Ah!
Yeah.
Yep.
Okay, well, I'm behind the times. I'm focused on getting my technology working here.
You
So.
should read the chat box, Karen. I put it on the chat box this morning. For PDL1 more than 1%. That is a discussion.
Okay. Yeah, you just, okay, I do see it now here, just a few seconds ago. Okay. I'm so glad you guys are keeping me up to date. Thank you so much. Well, we will then have to go make a revision to this study, so more to come on it, but thank you.
Next.
Okay.
Okay, and then we have the NACES trial, which actually we've discussed quite a bit, and Ray is on the phone here. Ray, do you want me to hand over to you? Do you want me to go through the review?
No, you can do it, Dwayne. Please go ahead.
Okay, so this is involving superior sulcus tumors, neoadjuvant chemoradiation plus or minus IO before surgery for superior sulcus tumors. It's a phase 2 trial of trimodality versus standard of care. Next slide. The ultimate schema looks like this. The patients have to be identified as a resectable T3 or T4 N 0 to 1, good PS superior sulcus non-small cell lung cancer. They randomize either to standard of care, which would be chemo with 4 doses followed by chemoradiation, surgical resection, and then postoperative standard of care and long-term surveillance. The treatment arm would include atezo plus chemo up front, followed by standard chemoradiation. This is followed by surgical resection in patients who are deemed to be surgically resectable. If they are not resectable, they will undergo the adjuvant therapy and follow-up. And then after surgical resection, the patients will be followed with a year of atezo. That was a battle that was hard fought and won to get that adjuvant tail. So congratulations to Ray and his group on getting that taken care of. Next slide. The primary endpoints were pathologic complete response, difference between the randomized arms between standard versus the treatment arm, and then secondary objectives were for overall and event-free survival. Of course, we're going to be looking at perioperative toxicities and treatment-related toxicities as well. And then there's some exploratory arms that you see here under other objectives at the bottom. Next slide.
So before we go to the next slide, I'm just looking at the chat, and it sounds like, Wayne, you've got 2 patients that you're...
We have not opened the study yet. We are in the process of working on getting the study open. What I was worried about as we were discussing this trial, and I'll be transparent about this, is that it seemed for a while that I was seeing a lot of superior sulcus tumors. And then I think what has happened over a period of several years is that we were just seeing fewer and fewer and fewer superior sulcus tumors. And perhaps it's because of the reason that both Ray and Valerie were speaking about, is that we just weren't seeing them over for surgery because there was a lack of confidence in what could be done with local consolidative therapy. I'm not quite sure. And when we went back and looked at our numbers of superior sulcus tumors that were treated by the surgeons at our institution, it had dwindled significantly year by year. And then I was just excited about the fact that we saw 2 as of this month. And so maybe with some excitement about multimodality therapy and some excitement or buzz generated around this trial, we'll start to see more of these patients come out of the woodwork so that we can get them involved in the trial. So that's where I was headed.
Thanks for the clarification there. And it does sound like, again, this is a great trial. It is multidisciplinary. It's asking an important question. There's been no advances in this disease in 20 years. Again, hopefully everyone will open it. It looks like, Ray, two sites have already opened. So that's fantastic.
Yeah, I'm really excited. There's a site with like a program with a gazillion number of sites, John Schallenkamp's program. I think that must be one of the Encores that opened it. So really excited to see that.
Awesome. That is fantastic. So thank you. Okay. We'll have
Any
a
other
race.
comments about the NACES trial before we move on to this exploratory?
Yeah, the only issue is, for those of you who checked your email, Atezo Adjuvant got licensed today, as whether that's going to cause some issues.
Yeah, so I don't think so, because of this superior sulcus subset. Those kinds of patients who receive neoadjuvant therapy as standard of care were obviously excluded from the Empower trial. So my expectation is, if people are paying attention and practicing evidence-based medicine, selecting patients appropriately, that problem really should not arise with this trial.
So let me understand the question, Ross. So you're saying on the control arm, which is now standard of care, those patients would be getting Atezo if they're
so it's the fact that yours is a kind of neoadjuvant-y sort of thing. But there's an aspect where then, the group which wasn't going to get Atezo, whether some people will say, well, but no, this is now standard of care in the adjuvant setting, with all of the caveats that Ray just mentioned.
Yeah, hopefully. I mean, there's a danger, of course, especially in community healthcare systems where people sort of practice by leaps of faith. The fact is, the superior sulcus patients get pre-op as a standard, pre-op chemotherapy and radiation therapy before they go on to surgery. So I think whether or not there is going to be a benefit for those people off trial to be routinely treated with atezolizumab is not one that anybody can have any evidence for in any foreseeable time to come. So hopefully that won't. We do need to message this clearly, that this is a data-free zone that we will be potentially bringing answers to, and we need to make sure we communicate that clearly.
Ray, I think you said it well. I think you have already alluded to the key differences and the key messaging. So we just need to run with that key messaging that you just nicely laid out, the difference there. So thank you.
And in terms of a contamination of effects, if the primary endpoint's PCR, then it won't affect our primary endpoint for sure.
Yeah, that's a good point, Wayne.
Okay. The trial that's currently being evaluated at a different arm of SWOG, but it crosses over because this involves a surgical subset of patients, is being presented by the Children's Oncology Group out of UT Health in San Antonio. The trial has come through, as I said, a different arm of SWOG, and they're currently in the process of being evaluated by CTEP, is my understanding. This is a phase 3 randomized controlled trial comparing an open versus thoracoscopic management of patients with pulmonary metastasis who have a primary osteosarcoma anywhere in the body. So the study involves patients who have less than or equal to 4 metastatic lesions in the lung. And what they feel over at Children's Oncology Group is that there may be a survival difference or therapy difference between patients who undergo minimally invasive versus open resection of these lesions. It is a multimodality group. Their primary, back one. You're right. So, sorry, go ahead one forward.
Okay.
Eligibility is patients who are less than 50. They have to have less than or equal to 4 lesions. At least one of the lesions has to be greater than or equal to 3 millimeters. So, you know, obviously these are not microscopic lesions. And then the patient will be randomized to open versus VATS within 28 days of imaging. Next. Primary endpoints will be determined if open versus thoracoscopic resection changes event-free survival in resectable oligometastatic pulmonary osteosarcoma. And then they'll be looking at things, other words of event-free survival, quality of life, overall survival. And then they were going to use surgical and imaging exploratory aims, which is to compare 30-day rates of perioperative surgical complications, patterns of recurrence, localization techniques for biopsy and diagnosis, and a relationship between the preoperative CT scanning and overall outcome in the presence of viable tumor in patients who were actually heavily treated with chemotherapy before arriving to surgery. And those are my slides on that study. Any questions or comments about that study that I could enlighten or bring light to?
What's the standard of care arm in that trial?
That is a great question. And there is, you know, it's almost a trial that could be brought about as a Bayesian approach because there's a bias depending on one group of another. Some people would consider open to be standard of care, and other groups would consider thoracoscopic to be standard of care. So the group that's bringing it forward feels that the open is standard of care and thoracoscopic surgery may have a potential for spreading of sarcoma or seeding if not done properly, and that it does not adequately address the metastasis into the lung compared to an open group. So I think that the group bringing it forward would consider open to be the standard of care.
Okay, because that factors into how you offer it to patients, et cetera. And the fact that here the standard arm, or sorry, the standard arm is being hypothesized to be better than the experimental arm, which is a little odd usually.
That's a good point. Okay. Thank you, Wayne.
Thank you.
All right, now we're going to have just a slight change in the agenda, and we're going to talk about a new trial that is planning to be activated shortly in November. November's not that far away, and we're very, very excited about it. And the study team has worked very hard. And so we have Dr. Hatem Hussein, who is going to be making this presentation on S1800D. Hatem?
Thank you, Karen. And it really is a pleasure to be here and speak with you all. And on behalf of John Rangel and myself, we're going to be presenting a new sub-study that will be opening in November, the S1800D. And it is a phase 2/3 study of N803, which is a IL-15 superagonist in combination with pembrolizumab versus standard of care in patients with stage 4 recurrent non-small cell lung cancer who have been previously treated with an anti-PD-1 or PD-L1 therapy. John Rangel has led many of the prior studies in this space, and he is at the Medical University of South Carolina, and I'm at the University of California, San Diego. So the S1800D is a study which will evaluate N803 combined with pembrolizumab to overcome PD-1 resistance. There are 2 cohorts. One cohort will accrue to a primary refractory patient population. So again, patients who progress within 3 months of a PD-1 first-line therapy. And then it will also look at second cohort, looking at acquired resistance, which is defined as progression after 3 months of therapy. The primary endpoint is overall survival. And the design is looking at, in the primary resistance cohort, a standalone phase 2 design, whereas in the acquired resistance cohort, a phase 2 and 3 design. Next slide, Karen. So as I mentioned, John Rangel has led much of this work in prior studies. He published a phase 1 study looking at the molecule N803, otherwise known as ALT-803, which is an IL-15 superagonist. And in a study combined with nivolumab, looked at patients who had progressed on PD-1 therapy. This was published in Lancet Oncology. Next slide. So what is N803? So N803 is a monoclonal antibody which has the effect of activating the IL-2 axis. And what is differential with this compound compared to previous iterations of IL-2 is that this is a molecule that spares CD4 cells, and as such actually can improve tolerability with this cytokine approach. The downstream result is to activate and expand CD8 T cells and NK cells. And this is an important area where there's a lot of translational work also describing the expansion of effector T cells in this space. Next slide. So here is a patient from John's practice. This is a 65-year-old female who had a KRAS G12C mutation and a PD-L1 of 70%. The patient received first-line therapy with carboplatin, pemetrexed, and pembrolizumab. And while the patient had a response of 40%, the duration of that response was not profound. And in fact, the patient had about 5 months before progression. At that time, the patient was started on trial with N803. And we can see that based on the first scan, there is a significant reduction in cancer that persisted. And in fact, actually, this patient has an ongoing response to this date 4 years later. Next slide. So the study will be divided into a treatment refractory cohort as well as a patient cohort that is relapsed, again, with acquired resistance. In the previous phase 1 study that was reported, there were responses seen. And here shows responses in the relapsed cohort. The total response rate from that phase 1 study was 29%, with a PFS of 9.4 months and an overall survival of 17.4 months. Importantly, there were responses in the PD-L1 negative patient population, of which there were 10. And the response rate in that category was 30%, with the disease control rate of about 70%. Next slide. So here represented are the most common AEs that were seen on the phase 1 study. The AEs were listed and here represent the most common in the table on top, as well as other serious or related adverse events on the table on the bottom. The most common were injection site reaction, fatigue, flu-like symptoms, and there were other symptoms seen, such as nausea, anorexia, chills, and fever. Importantly, there were some rare circumstances of hypotension, and both John and myself are available for any other questions on the AE profile with this compound. Next slide. So here is a schema of the study design. As I mentioned, patients are included after prior therapy with a PD-1 or PD-L1 antibody with disease progression. If patients have progression on therapy within 12 weeks of the PD-1 inhibitor, those patients will go into the primary resistance cohort, of which the sample size is 130 patients. And this is a randomized cohort between N803 plus pembrolizumab versus standard of care. And the standard of care is docetaxel plus ramucirumab, or docetaxel alone, or gemcitabine or pemetrexed. If patients have had progression on therapy after 12 weeks of a prior PD-1 therapy, those patients will go into an acquired resistance cohort. The sample size is larger in this cohort, and patients are randomized between N803 plus pembrolizumab and the standard of care options that I mentioned before. So with that, actually, we're very excited about this study. Again, it is anticipated to start next month. And again, this is a trial that will address an unmet need in an unmatched patient category. And we're really, both John and myself are accessible for any questions from any of the activating sites that that the study will be at. So really looking forward to participating and working together on this study.
Thank you, Hadam. So this is open for a discussion. Does anyone have any questions about this study? We are very excited about it. It really is a clear unmet need, and we're going to take an opportunity to evaluate a novel agent here. So not seeing anything in the chat or hands raised.
Well, Karen, I'll just jump in.
Okay.
This is Ray. Her team, you're probably aware that there is a trial called the Quilt Trial. Yes. That's using this agent in the first-line metastatic setting. So there is a chance that might, I guess, programs that have that trial open may have some difficulty getting people into this. This is second line, right? Second line and beyond. Mm-hmm. Yeah. Just be aware of that.
No, thank you so much, Ray, for that, for that guidance. And that actually did come up in our prior discussions regarding this study with the FDA as well. I think there are some important differences on the reporting of when the Quilt study is anticipated to have data available versus, with this study, actually even kind of the anticipated, release of some of the data. And so I think we are, still excited, and from both the company, which is the sponsor, is Immunity Bio, as well as our team, we're really excited about at least, having, some of this info before the first line study comes out,
Well, I think since this is such a huge unmet need and we have over 800 lung map sites, I'm thinking that this is going to accrue really quickly. So I think that's the other important point, and that's why having those 800 sites and that lung map infrastructure is so important. So I think it will accrue incredibly fast. Okay, all right. Thank you again, Hadam. All right, we're going to now turn the program over to Dr. Daly for updates on our radiation oncology trials.
Terrific. Thanks so much, Karen. I'm excited to give the radiation oncology update for the fall meeting. We can go to the next slide. Here's our agenda. I was first asked just to spend 3 to 5 minutes running through recent high impact publications and presentations from clinical trials and other cooperative groups or multi-center groups around the world. So we'll just spend a couple of minutes talking about those and how they may fit into our own portfolio. And then we'll run through an update on our active SWOG studies from each of the PIs. And then a very brief update from our study champions on each of the active SWOG endorsed studies. Next slide. So when talking about recent high impact cooperative group trials in the radiation space, I think it's important just to briefly mention the Lung-ART trial that was presented at ESMO 2020. We're still waiting on the full length publication eagerly, but Lung-ART, as I think most of you know, was a randomized phase 3 trial asking the very important question of whether we should use mediastinal postoperative radiation following complete resection in patients with stage 3 non-small cell lung cancer. This was a large European trial. They randomized over 500 patients. and found that there was a higher rate of high-grade cardiopulmonary toxicity with the use of postoperative radiation. The 3-year disease-free and overall survival were unfortunately similar between the two arms, although port was found to be associated with a non-statistically significant 15% increase in disease-free survival among the patients with N2 disease. So next slide. Also, I think overall, we're eagerly awaiting the full manuscript for a more nuanced details on the patients that were enrolled on this study, the burden of nodal disease, and any subgroup analyses. But currently, based on this publication, this presentation, I think most of us would argue that there's no role for routine use of postoperative radiation in postoperative N2 lung cancer patients who've had a complete resection and did not have gross nodal extracapsular extensions. I think this was potentially a practice-changing trial, though a lot of open questions remain about the some of the details of the patients, and hopefully that study will be coming out very soon. We can go on to the next slide. And I think particularly relevant to some of our SWOG and SWOG endorsed studies was 2 recent trials looking at the question of hippocampal sparing in prophylactic cranial irradiation. The PREMOR trial was just presented at ESMO 2021, and a very similar trial was published in the JTO also this year. These were both phase 3 randomized trials with similar patient numbers. They both looked at cognitive endpoints, but they were somewhat different cognitive endpoints, which may be important in understanding the differences between the studies. So the PREMOR trial was a negative trial. Their primary endpoint was decline at 3 months on a DFR. The PREMOR was the positive trial, and the Belder-Bose trial was the negative trial. So the PREMOR, using a patient-reported outcome, found that hippocampal sparing did better preserve cognitive function at 3 months. And by contrast, the trial published in JTO in 2021 found absolutely no difference in cognitive preservation with hippocampal sparing PCI. So very interesting that we have 2 similar trials showing different endpoints. Can you go to the next slide? Just a few additional details on the PREMOR trial. It was a phase 3 randomized design. The majority of patients had limited stage small cell disease. The primary objective was delayed free recall at 3 months. And they found that this decline was lower in the hippocampal avoidance PCR arm with highly statistically significant results. And the incidence of brain metastases, overall survival, and quality of life were not significantly different, suggesting this, the use of hippocampal avoidance did not increase rates of recurrence in the spared areas. Next slide. And then by contrast, the trial from the Netherlands, also a phase 3 trial with 168 patients with a primary endpoint of total recall on the Hopkins Verbal Learning Test at 4 months. Absolutely no difference between the 2 arms, p-value of 1.0, and no difference in overall survival between the arms. And this study has been published in full manuscript form. So where do we go from here? On to the next slide. And that's where several ongoing trials may be important. So first, there is an Nrg trial looking at essentially the same question, but in a much larger patient population, Nrg CC003. And Dr. Gaspar is our SWOG champion for this study. They'll enroll over 300 patients. Their primary endpoint is actually related to disease control, but they have secondary endpoints related to cognitive endpoints as well. So I think those results will be very important. And then, of course, Dr. Rusthoven's Maverick trial, looking at the important question of whether we need PCI at all. And his trial does allow hippocampal sparing, as you'll be hearing in just a moment. And then additionally, the Nrg CC009, looking at the role of hippocampal avoidance in the treatment of brain metastases. So lots have been a few exciting trials in the radiation space, and hopefully there'll be a number more in the upcoming year. So on to the next slide. So I think we can now go to our update on the active SWOG studies, and we can go to Dr. Rusthoven, who I believe is on the call.
Can I just, I'm sorry, maybe to interrupt. There is a question in the chat from Judy about, did both of the hippocampal sparing trials use patient-reported outcomes or physician-reported?
So my understanding is the PREMER trial was a patient-reported outcome, and the trial from the Netherlands used a physician-reported outcome. I think Dr. Rusthoven is also very familiar with these trials, so he can interject if I am saying anything that's not entirely correct.
That's really important. If one used one and one used the other,
yeah,
that could explain some of the differences.
Yeah.
Thanks.
Yeah. All right.
Thank you. So I can give an update on the SWOG S1827 Maverick trial. I know people here are familiar with this study. It's a randomized phase 3 trial of brain MRI surveillance plus or minus PCI in patients with both limited and extensive stage small cell lung cancer. Next slide. So briefly, the background with PCI, it's a therapy that's been around for a number of decades. Historically, it was a response to the high rates of brain metastases that are observed with small cell lung cancer. And indeed, it's very effective at reducing the rates of brain metastases. It cuts them in about half. And some studies in the 90s and 2000s showed that this was associated with an overall survival benefit, first in a meta-analysis in limited stage disease, and then in a dedicated randomized trial in Europe in extensive stage disease. But these studies were criticized due to the heterogeneous and often absent brain staging and surveillance regimens, often in the pre-MRI era. And there was a subsequent randomized trial in Japan looking at extensive stage disease only that tried to address this. And that randomized trial included MRI surveillance for all patients plus or minus PCI. And in the context of that randomization, again, PCI reduced the rates of brain metastases significantly, but this did not translate into an overall survival benefit. And the thinking is that perhaps if you're catching brain metastases a little bit earlier with MRI surveillance, you can intervene and offer more effective salvage therapy. And perhaps this would mean that we don't need to offer PCI to all patients. So now the status is we have conflicting survival data in randomized trials in extensive stage, and we've never actually asked this question about MRI surveillance plus or minus PCI in limited stage disease. Next slide. And so here are the contemporary Npcn guidelines, and you can see at the top in green that prophylactic cranial irradiation is still the standard of care for limited stage disease, and that's because the meta-analysis from 1999 is still the best data on limited stage disease that does show a survival benefit with PCI. In extensive stage disease, the guidelines give us the option of offering PCI to consider PCI, and that's in response to the conflicting randomized data on PCI in extensive stage. And then over in purple on the right, you can see that MRI surveillance is now recommended for all patients regardless of PCI status. Next slide. So that brings us to our schema slide. So this is the Maverick SWOG S1827 study. And again, this is brain MRI surveillance plus or minus PCI, and it includes both limited and extensive stage disease, which is an important point. And for those that participate in this study, people have strong feelings about PCI, both for and against in certain populations. And so I would just remind folks who have it open that you're welcome to offer this study to any group of patients that you have equipoise about. So some sites will enroll both limited and extensive, some sites just limited, et cetera. And so that's totally fine in the context of a large randomized trial. And so the basic schema for this study is that all patients receive MRI staging to confirm that they don't have brain metastases. And then all patients receive brain MRI surveillance, and they're randomized in a simple one-to-one fashion to prophylactic cranial radiation or not. And then they're followed. And the primary endpoint is overall survival. And some technical things, we really tried to emphasize low barriers to accrual and to be welcoming to all forms of local practice patterns. And so things like hippocampal avoidance are allowed in the study. Any and all NCCN acknowledged paradigms for first-line therapy are allowed. Different techniques for offering salvage therapy are okay as well, and stereotactic radiosurgery is fine to offer when patients develop brain metastases or whole brain radiation. Next slide. So some notes of this this study has been endorsed across the Npcn, including in Canada, and it's specifically championed in the VA system as well. And it's starting to get opened in some of our SWOG international sites. Yesterday, we found out the study is fully open in Saudi Arabia, which is exciting, and we're hoping that some of those partners will be able to accrue some patients as well. Again, it's a pragmatic design. We really are trying to lower barriers to accrual. And this covers some of the things that I said on the last slide, but pretty much anything that's reasonable as a standard therapy option is okay. And as Megan was pointing out, there's now conflicting data on the value of hippocampal avoidance PCI. And so hippocampal avoidance PCI or standard PCI are both okay on this trial, and we will actually be tracking that prospectively, so we will be able to add some more data on that important question. In general, our baseline approach is to be welcoming to dual enrollment on other clinical trials where possible. And so, the thinking behind this is, we don't want to exclude patients from their ability to get novel therapeutics, specifically on other trials. So, if you have questions about patients and whether they can be enrolled on other trials, please just reach out to us, and we'll try to work with you to accommodate wherever possible. We had a recent amendment in May that significantly extended the window of eligibility. So initially, it was 8 weeks post the last cycle of chemotherapy, and we were able to extend that to 16 weeks, which we hope will only further lower barriers to accrual. We're also working with the community engagement subcommittee, and we have a kind of an interesting approach to promoting the trial via the mednet.org, which some people may be aware of, which is a nice question and answer forum that a lot of radiation oncologists and medical oncologists participate in. And so we thank Dr. Housery for helping us promote the trial via that platform. Our total accrual as of 10/13 is 64 patients. And so, we are accruing, but it's always going to be the thing that we focus on and try to promote. So we really appreciate those on the call who have the trial open and are offering this to patients. We understand that there are some challenges to accrual, COVID, which has been disrupting really all trials over the last year and a half to some extent. There's also some competing trials in the small cell space. And in general, this is kind of a challenging randomization. So I wanted to go over some strategies and things on the next slide that we've kind of learned over time in terms of how to talk about this trial with patients. Next slide. So notes on patient counseling and enrollment. So PCI is an endorsed NCCN treatment, but patients can choose to have it or not have it off trial. And so that always makes it challenging when you're talking about a randomized trial, because patients and MDs often have strong opinions about PCI, and that's understandable. So some things that I've learned that can be helpful when talking to patients is I think it's actually very valuable to walk patients through why PCI is considered a standard therapy and what we're trying to accomplish on this trial. And I found that can really be helpful in kind of breaking down barriers and helping patients to consider whether to enroll. So it is true that small cell has very high rates of brain metastases, and over 50% of patients will likely develop them with this diagnosis. And PCI very consistently cuts these brain metastases rates in approximately half. And I've had experiences just kind of walking through these 2 points where patients say, all right, give it to me, stop right there. And I say, whoa, let me tell you a little bit more about the survival aspect and the conflicting randomized data. So I think sometimes as providers, we underestimate how important that reduction in brain metastases can be to individual patients. And it's very important to talk about that. That part is not in question about PCI. It will reduce brain metastases. Now, older studies showed that this translated into an overall survival benefit, but this is now debated with conflicting data in the MRI era, specifically in extensive stage. PCI is still really the unquestioned standard of care in limited stage, and there's never been a trial, to my knowledge, looking at this question of MRI surveillance plus or minus PCI. This is the first trial to look at that, and MRI surveillance alone is the experimental arm in this trial, whereas PCI is the standard of care. And then just one additional bullet point is never underestimate the power of altruism for human beings and for our patients. For many patients, I've found that the most attractive reason for participation in a trial like this, where they can have either therapy off trial, is knowledge that the the data that we generate will help future patients in their situation. And I've started discussing this, just, I make this point to every patient that this is one of the benefits of enrolling on a trial. And many patients tell me that that's actually the most important thing to them. So I think that it's worth mentioning that and acknowledging that sentiment that patients have. Next slide.
That's the last slide there, Chad.
Oh, okay. Sorry. So I was just going to mention that I'll just mention briefly.
Oh,
then
sorry.
the
I'm
next...
sorry. I'm sorry, Chad. You do have another.
No problem. So just one slide on this in the interest of time. So there's a trial that's related to the Maverick trial. That's the Nrg CC009. And this is for patients who have already developed brain metastases. And so this is a phase 3 randomized trial of SRS versus hippocampal avoidant whole brain radiation for 10 or less brain metastases from small cell lung cancer. And so we've tried to kind of line things up so that if patients who are in the MRI surveillance alone arm of the Maverick trial develop brain metastases, that this trial could be an option for them as well, because radiosurgery and whole brain radiation are both allowed on the Maverick trial. And to our knowledge, this is the first randomized phase 3 trial involving SRS alone for small cell brain metastases. So it's an exciting trial that's kind of looking at a very well-established paradigm in other histologies that really just hasn't been studied yet in small cell. So please keep this trial in mind as well for your center if you think it's a good fit.
Chad, just one comment. I saw a few people with small cell lung cancer after limited stage, extensive stage. I went over, all studies showed decrease in brain metastasis. Some studies showed improvement in overall survival. Patients seem to be interested in, participation in the study. Then, when they go and see my radiation oncology colleagues, and then they go over possible side effects, then they did not enroll. So do we have percentage, mainly the memory loss, because prophylactic cranial radiation generally is well tolerated, not as therapeutic, but do you have percentage? If you tell them that small percentage, they'll be more interested.
Yeah, so is the question, do we have good data on the cognitive effects of PCI?
Like what percentage of memory loss or other possible side effects?
Yeah, so it's always important to define your terms of what memory loss means. Most of these things are evaluated based on batteries of cognitive tests, and then whether patients have 1 standard deviation or 1.5 standard deviation declines from baseline to some follow-up endpoint. So there's a little bit of heterogeneity in them. I would say that, and I can share with you some data on that. I usually keep that in the slides, but for the interest of time, I left it out. But the data on PCI specifically is not that great in terms of randomized data. So a lot of it is actually retrospective, but it does suggest that the toxicity of PCI is pretty similar to whole brain radiation, that you will have an increase, you'll have a decrease in performance on these cognitive tests that's going to be higher in your PCI arm versus the no PCI arm. So a lot of that is extrapolated from the whole brain literature. And then there's this caveat that, because the brain metastases are so high in PCI, in small cells, that those can affect cognitive function too. And so, if you're reducing those brain metastases with the PCI, then it's actually possible that the difference in the cognitive preservation between the arms might not be as great as what you see in whole brain radiation in other histologies. So this trial, actually, because it has prospective cognitive testing, it's actually testing that as one of the key secondary endpoints, because that is a bit of a gap in the literature. So we will have data on that from this trial. I would say that our hypothesis is that there will be more cognitive decline in the PCI arm based on the data that is available. It's hard to put a percentage on that because you really have to define your terms in terms of what you're testing.
I have a quick question for you, Chad, please. And I know this is anecdotal, but could you say about what % of the patients you present this study to agree to participate and are comfortable with the randomization?
Yeah, that's a good question. I would say that in my personal experience, it's probably 1 out of 3 patients that I present the trial to and walk through it that they want to enroll. That's actually gotten a little bit better as I've gotten more comfortable or more experience talking about these things. Because I think, that's why I spent that time making that slide and going through it. I actually really think it's important to explain to patients why PCI has been considered valuable, what it actually does, and where the question marks lie, and to not assume that the only thing that a patient will care about is overall survival, because the reduction in brain metastases is really, really important. And like I said, the altruism is important too. But if I had to put a number on it, I'd say probably 1 out of 3.
That's good to
that I
know.
offer it
Thank
to.
you.
Yeah.
Thanks a lot.
So Chad, this is Ray. I think I reached out to you a few weeks ago. I believe it's LUN005, the limited stage small cell lung cancer plus minus atezo trial. We find that they don't let us offer Maverick to patients enrolled into that trial. Any backroom brokering being done to maybe address that?
The short answer is, we discussed this with them at the time that we were developing Maverick, and they decided that they couldn't allow dual enrollment from their trial onto Maverick. And there's some reasons they have for doing that. And that's something that we had hoped for, but it didn't work out. So unfortunately, I don't think that there's much wiggle room. Perhaps the silver lining is that that trial has accrued so well that that trial may be actually completing accrual within the next 1.5 years or so. And they do see patients earlier in the process because that's a first-line, study. So they're seeing patients at diagnosis. We're seeing patients after they've completed first-line therapy. So, there's not much you can do. But that's a great trial. It gives you access to atezo and limited stage, and certainly we support it. It's too bad that the dual enrollment thing didn't work out.
Okay, so I think we'll move on to S1914 now. This is a phase 3 randomized trial for early stage medically inoperable non-small cell lung cancer, comparing radiation alone to radiation with atezolizumab. Next slide. So first, why this trial? So SABR or SBRT is the standard of care for early stage medically inoperable non-small cell lung cancer, and it results in high rates of primary tumor control, but regional and distant recurrences remain problematic. And chemotherapy is often not well tolerated in this typically frail patient population. Immunotherapy is an appealing strategy to improve regional and distant control. And we recently conducted a phase 1 single institution trial demonstrating that immunotherapy is safe and well tolerated in this patient population. Next slide. The primary objective of S1914 is to compare overall survival in patients with inoperable early stage non-small cell lung cancer randomized to SBRT with or without atezolizumab. Secondary objectives include progression-free survival, which is a key secondary objective, as well as distant, local, regional, and local failure rates and frequency and severity of toxicities. Next slide. This shows our schema. Our target is to enroll and randomize 480 patients. Patients on the experimental arm will receive a total of 8 cycles of atezo. The first 2 cycles will be delivered prior to initiation of SBRT, which will be started with cycle 3, and patients will then be followed. Patients on the control arm receive standard of care radiation alone. This is meant to be a pragmatic design, so we allow a range of acceptable SBRT fractionation schemas. Atezo is given on a Q3-week basis, and stratification factors include location, tumor size, and Zubrat performance status. Next slide. Some of our key eligibility include a requirement for patients to have biopsy-proven disease. Tumors can be up to 7 centimeters in size. and they do have to have at least one high risk factor suggestive of increased risk of recurrence, either a tumor diameter of 2 centimeters or more, a tumor SUV max of at least 6.2, or poorly differentiated histology. Patients cannot have evidence of nodal disease, and they should be either medically inoperable or have clearly documented unwillingness to undergo resection. Next slide. Important to the exclusion criteria, we have now clarified that the prior treatment for lung cancer is only for the current lung cancer diagnosis. So patients who have already underwent some form of neoadjuvant therapy for their current diagnosis or have a recurrent disease are not eligible. However, patients who have had prior lung cancers, such as a prior lobectomy for lung cancer, those patients are eligible. However, they cannot have prior overlapping radiation fields, and otherwise fairly standard eligibility criteria for these patients. Next slide. Key points, this is a common malignancy in a patient population who really need better therapy option. We believe it's a fairly pragmatic design. We allow essentially all of the standard radiation dose fractionation schemas. Important to patients, there is no placebo control. So patients who, unlike the other trials in this space, patients who are randomized to the control arm do not have to receive a placebo. And we're delivering only 6 months of systemic therapy as compared to 12 to 24 months on the other randomized phase 3 trials in this space. Next slide. As of this morning, we've accrued 58 patients of a target of 480. We have 267 active institutions. So we would love to get more people accruing to this study. Accrual has picked up a bit recently, but we would still like it to pick up more. And I'd be happy to answer any questions that anyone has about S1914.
I'm not seeing any questions in the chat box, Megan.
Okay.
Megan, question. So for a trial that's looking for essentially medically unresectable patients, why do we have such stringency with the cardiac function deal there? We've had a number of our patients not qualify because the EF was fractionally below 30%.
I believe that that recommendation initially was related to the atezo. That is something we could revisit. I think it's important to note that assessing ejection fraction is not required. It's just if the patient has a known ejection fraction below 40%. But that is something that we could look into, whether we can loosen that. I appreciate that feedback. That's helpful.
So there's another question in the chat. Does it require radiation certification?
So it does require a credentialing for radiation delivery, yes. Although if you have been credentialed to do SBRT on prior Nrg trials, you should be fine. It's the same credentialing. And if there's any other questions about the requirements, please feel free to reach out to me and I can get you in touch with the right people. All right.
Yes, Harad Al-Jumaidi, I can present SWOG 1933. So this is our pilot study of hypofractionated radiotherapy followed by atezolizumab consolidation stage 2 or 3 non-small cell lung cancer with borderline performance status. Next slide, please. So there is no evidence-based data to guide treatment decision in patients with a stage 3 non-small cell lung cancer with performance status 2. Those patients were excluded from phase 3 studies that define the standard of care, and stage 2 patients who are not candidate for surgical resection. And some of these patients are treated with radiation only, some are treated with radiation followed by chemotherapy, some are treated with concurrent chemoradiotherapy with no data to prove efficacy and safety. Basic science and clinical data support the synergistic activity of radiotherapy and immune checkpoint inhibitors. A previous study by Encore et al. Showed that hypofractionated radiotherapy was better tolerated than standard fractionation, and in this same patient population was single agent radiation with similar outcomes. And we know from multiple studies that immune checkpoint inhibitors were better tolerated than chemotherapy with less treatment-related AEs and grade 3 and higher treatment-related AEs. Next slide, please. So key inclusion criteria is patients with stage 3 non-small cell lung cancer with performance status 2 or stage 2 patients with performance status 0 to 2 who are not surgical candidates. This is inclusion for step 1, and for step 2, which is the radiation, hypofractionated radiation. For step 2 after hypofractionated radiotherapies, atezolizumab consolidation, patients who receive at least 45 gray of radiation with no disease progression on scans. Key exclusion criteria: active autoimmune disease or interstitial lung disease, grade 3 or higher pneumonitis. Next slide, please. So that's the schema. So stage 3 patients performance status 2 or stage 2 patients with who are not surgical candidates. So they get hypofractionated radiotherapy, which is 60 gray and 15 fractions over 3 weeks. Then 2 to 5 weeks after completion of radiation, they get scans, and patients with no disease progression and receive at least 45 gray of radiation go on to receive atezolizumab consolidation for up to 1 year. Next slide, please. So currently the study is open 94 actually institutions per yesterday email. We have 11 patients enrolled. So enrollment picked up a little bit over the past few weeks. We have more centers, the study is open, and so I encourage everybody to look for these patients. These patients are there, like per previous publication, and it's in the background of this study, up to 30% of patients that we see in the clinic with newly diagnosed non-small cell lung cancer have performance status 2, and patients with stage 2, there's good percentage who are not surgical candidates, and I think this study provides a good opportunity here. Now, 2 feedback that we got from our community engagement committee was one was about the DLCO 50%, and we had discussion with our radiation oncology colleagues. The idea was to keep the DLCO as 50%, but it's not specified in the protocol that we need to use the absolute DLCO. So adjusted DLCO could be used for hemoglobin or for alveolar ventilation. And the other feedback was to allow like standard fractionation. We decided at this point in time to keep it at hypofractionation, hypofractionated radiotherapy, and kind of like think about it later. But I'm open to any questions or any suggestions to increase enrollment.
So Rod, this trial has picked up accrual. So again, I want to thank everyone for accruing to this study. I think you have about 11 patients on now. How are they doing?
The patients that I'm treating here, they are doing very well. None of them had grade 3 or higher treatment AEs. I had one who had grade 2 rash, responded to steroid well. And there so far no grade 3 or higher treatment-related AEs.
All right, thank you.
Hi, this is Matt Harkenrider. I am the SWOG study champion for this study, ECOG-ACRIN 5181, randomized phase 3 trial of durvalumab as concurrent and consolidative therapy, or consolidative alone for unresectable stage 3 non-small cell lung cancer. Next slide, please. And here's the randomization. So this is unresectable stage 3 non-small cell lung cancer. And the 2 arms are essentially the Pacific backbone of platinum doublet chemo radiation with durvalumab for 1 year, compared to the same regimen with an additional 3 cycles of durvalumab given in the concurrent phase with the platinum doublet chemo radiation. So pretty simple randomization. Next slide. And here's just a slide on updates of accrual. The primary objective is overall survival. The targeted accrual goal is 660 patients. As of earlier this week, it's at 243 patients, which is 30% of the target. I think that in the last, this trial's accruing about 20 patients a month since my last update. So it's accruing very nicely. SWOG has about 21. I think that the most recent number might be up to about 24 patients in the accrual. So hopefully we can all open and accrue to this study. It is a pretty easy study to accrue in my experience. So if anybody has any questions or concerns, please feel free to reach out. I'll be happy to support.
Yes, Matt, you're right. I didn't get a chance to update those additional numbers. So you're right. It's 24.
Okay, I think Dr. Gomez was not able to make it on the call, so I will present his slides for him. This is Nrg Lu002. Dr. Gomez is the SWOG study champion for this study. And this is a trial in metastatic non-small cell lung cancer patients with limited metastatic disease following frontline systemic therapy. So eligible patients complete at least 4 cycles of first-line induction systemic therapy, which can include chemotherapy or chemoimmunotherapy. And they are randomized between maintenance systemic therapy alone and maintenance systemic therapy with consolidative therapy up to 3 discrete sites of disease, which can be stereotactic radiation or radiation or non-stereotactic radiation or surgery. I think we can go to the next slide. The total accrual is 207. It looks like accrual has been picking up, although not necessarily through SWOG, as we've only accrued 2 patients through SWOG. So I think most of the accrual thus far has been through NRG. And I know there have been major attempts by the study team to increase accrual on this trial. And I'd be happy to try and take any questions for Dr. Gomez.
I'm not seeing any, Megan.
All right, so then we can go on to Nrg Lu005, and I believe Dr. Shu is on the call to present.
Sure, thank you, Dr. Bailey. So again, we briefly touched base on this. This is actually now phase 3 study looking at limited stage small cell lung cancer, randomizing between standard chemo-RT versus chemo-RT plus atezo concurrently, basically building off of the Empower 133 data. If you can go to the next slide, please. So in brief, basically the study's been accruing very well. Total study goal is 506 patients. Currently it's at 340 and 294 of them are assigned to NRG. So if it is possible to have basically people from SWOG, please accrue to this or assign this to SWOG, that'd be great. Currently the credits assigned to SWOG are actually 9. So if we can improve that'd be great. But I think in general, most institutions are assigning it to NRG. So again, the primary objective is to determine whether or not the addition of atezo will actually improve survival amongst these limited stage small cell lung cancer patients. There are various other secondary objectives. And again, the inclusion criteria, as you can see, are on the slide. They stratified by the radiation treatment schedule, as well as the type of chemo, either cisplatin or carbotaxol and carboplatin, and also sex and ECOG. And again, it's a 1-to-1 randomization, and cycle 1 of chemo must be given prior to the study entry. So that's very important, as well as the chemo regimen having to be declared. Again, as discussed a little bit earlier, PCI is highly recommended, and the Maverick trial is not, you cannot enroll in that study if the patient is enrolled on this study. So that's the major updates on this trial. And just if we can, just continue to accrue and accrue through SWOG.
Any questions for Charles before we move on? Okay, so I guess next we have the Lu006, and I believe Dr. Samstein is on to present.
Yeah, hi, Robbie Samstein. I can briefly review the Lu006 trial, which is a trial focusing on a rare disease, mesothelioma, asking the question of whether there's a benefit to adjuvant imprint radiation or adjuvant radiotherapy, hemithoracic radiotherapy in a randomized clinical trial. We can go to the next slide. And the major objective of the trial is, again, to look for an overall survival benefit of the addition of, or asking the question of whether there is an overall survival benefit with the addition of adjuvant radiotherapy in addition to standard treatment of adjuvant chemotherapy, as well as standard secondary objectives and safety targets. The goal is 150 patients that will be randomized in a 1-to-1. And I think overall the study was opened right before COVID in January 2020. So accrual has definitely been on the slow side. I think current accrual is still updated there at 5. And there's a big push to try and open the trial at centers that see these patients, that see mesothelioma patients and operate on them. I think there's currently only 20 sites open. So we're really looking to get it open at as many sites as possible.
All right, any questions for Dr. Samstein? I don't see any in the chat, so I think we can move on to Raptor Lu007, and Dr. Park will be presenting.
All right, thank you very much. So this is the Raptor trial, Nrg Lu007, with atezolizumab versus consolidated thoracic radiation with atezolizumab for extensive stage small cell lung cancer. So the basic question here is looking to see if consolidated radiation still helps after chemoimmunotherapy, even though we know that it does help after chemotherapy alone. So now using the Empower 133 regimen of etoposide platinum with the tezo, up front, and then assuming no progression, having maintenance of tezo afterwards. The question is, do you add radiation to not only the initial sites of disease in the thorax, but also up to 5 sites in total? So the phase 2 target is 138, with the primary endpoint being progression-free survival. The phase 3 target being higher, 384, with the overall survival being the primary endpoint. And then, so the main thing here is that there have been a couple amendments that have been approved recently. They do encourage co-enrollment on Maverick as well, so I'd highly encourage that if you have both open at your sites. They also will allow for co-enrollment on Nrg CC003 as well, which is almost done accruing, but that's the PCI trial with or without hippocampal avoidance. But certainly for SWOG, we would encourage you to do both this trial as well as Maverick and get double credit for SWOG during that, for those 2 studies. They've so far accrued 16 patients overall, so it's been pretty slow. We've had 0 from SWOG so far, but hopefully this could be increased both here at SWOG as well as nationally.
So I'm sorry, we're going to have to do a little quick change out in the slides. So give us 1 second here for the second portion of the slide set. It was very large. So give me a second and we'll get the second portion. But I think, Megan, I think that's the end of the radiation.
That is the end of the radiation section. Were there any last questions before we wrap up?
Can I ask a quick question about the Raptor study, Lu007? We've been having a lot of trouble accruing to this. I don't quite understand why. I think it's a great study, but for some reason I'm having difficulty identifying these patients, even at tumor board. And I wanted to see if other institutions have had similar issues. I just don't quite see why we're not able to accrue to this. And I'm wondering if there's something that I can do with my medical oncologist colleagues to try to improve accrual.
I think a lot of it, it's I think challenging for a few reasons. One is not everyone's using atezolizumab. Some people are using durvalumab. They're going to start having monthly calls pretty soon as well to try to figure out accrual issues. So they haven't had that yet, but they're about to start soon. So I think that's one question that's going to come up that a lot of people are struggling with is which patients can be, where do we find these patients? I think a lot of people are not necessarily even referring to radiation oncology necessarily upfront for these patients. So I think more awareness will be helpful. But so far, they haven't done any amendments to allow durvalumab from the Caspian study, but hopefully that's something they can discuss soon.
Okay, thank you.
All right, thank you, Dr. Daly. And I really think it's fabulous that we have all these radiation trials as well. So it's great to see. And now we're going to move on to Dr. Mack and the translational medicine session.
Okay, thank you very much. And I apologize in advance, Karen, because there's a bunch of fiddly little animations in here. If you want, I can share it from my own screen. It's up to you.
Okay, let me stop sharing, and then you can, should be stopped. Is it?
Yep, stopped. Okay, are we restored? You can see that fine?
I can.
Okay, great.
You can see it.
Can you see it, Fred?
Yeah, I see it.
Okay.
So following on the theme that Dr. Kelly started the whole thing with, we are focused on getting our manuscripts out. And primarily, first of all, would be the 1403 correlatives. The plasma kinetics are the most interesting, and I will show you some updates in that now, the final figures. There will be another paper coming from this focused on the tissue correlatives from the Yale team, Katie and Sarah. And I think we can even have other papers on innate and emergent resistance mechanisms for afatinib-based therapies, and even CHIP, because this study has revealed a lot. Considering that it was ultimately a negative study in terms of outcomes, it's really amazing how much information we were still able to glean from all of this. Additionally, I've heard it from our contractors, the vendors, that the 1507 correlatives are now complete. I have not actually seen it. Maybe they went straight to stats, but hopefully we'll be able to move forward on that. And as Dr. Kelly mentioned, the 0819 is now in press, and we have lung mat manuscripts that are in various states of preparation, led by either David Kay, myself, or Fred Hirsch. So again, we'll be focusing just briefly on plasma kinetics. And I wanted to show some other things, to be perfectly honest, some other updates, but some of this we haven't shown before, and I think you may find it interesting. So first of all, just as a reminder, the SWOG 1403, that was a trial of afatinib versus afatinib plus cetuximab, led by Sarah Goldberg. And the key thing to remember here is that all of the patients were known to be EGFR positive before entering the trial out of tissue. And so here, looking at the correlatives, the final analysis is that at baseline, 77% of the patients were EGFR positive. Remember, when you have the more indolent, slightly slower growing tumors associated with driver mutations, the detection is a little lower. That's, in comparison, say, to KRAS mutants or squamous, where you can get up to 90% in non-small cell lung cancer. So it's pretty close to what we observed. The median variant allele frequency was 1.26 for those of you who like numbers. The mean was much higher, and that's because the range stretched really high. And we'll look at that briefly. And there were no associations between baseline positivity, whether we could detect the EGFR or not, and basic demographics, sex, ethnicity, smoking status, weight loss, even performance status. There was a little association with age, where younger patients were more likely to be baseline positive, which is a little interesting. But the real significant differences we saw here are in the M classification. If you look at whether a patient was M1A versus M1B, the extrapulmonary metastases, there was a significant difference in detectability, with obviously the ones with extrapulmonary metastases being much higher and easier to detect. And specifically, the location of the MET seemed to play some role in this. We were able to detect plasma in every patient that had a liver MET, compared to only 71% with those with no liver mets. And brain mets, 93% of them were detectable versus 72%. EGFR baseline, we are wrestling with this right now. If you dichotomize this by positive and negative, there doesn't seem to be an association survival at that sort of higher level. But it turns out that if you analyze it as a continuous variable and you adjust for copy number gain, which in itself is proving to be very interesting, we do see slight improvements in outcome for patients with lower levels. And we are expecting this to be, and I put this in quotes, a prognostic effect. We can't prove it's prognostic because every patient was treated, but it stands to reason and has been observed in previous studies that tumors that shed less are probably less active, less genomically unstable, less aggressive, less total tumor content than those that shed more. Shedding more would be considered a negative prognostic factor, and we see that a little bit. But we do have to untangle the copy number variance. And that's because, you know, about 30% of the cases have EGFR amplification, which is determined independently from the variant allele frequency. And we see a very significant difference, which I think is pretty obvious to see between the cases that have amplification of EGFR versus no amplification. And here we're looking at the variant allele fraction on the y-axis. And you can see that there are cases up in the 80%, 70%, 60%, very high variant allele fractions, but those are always associated with amplification. On the right side, you have some that are creeping into the 20%, which is very high, with no evidence of amplification. And it's a bit circular to point out that the ones without any amplification or copy number increase are the ones that have the zero mass, because obviously that copy number increase is making it easier to detect. And so one has to wonder if some of those really low ones or zero ones might have been positive if they were amplified. And the last element of the paper that we are doing right now is looking at copy number gain, because it looks like there's actually some significant effects on survival based on the presence or absence of copy number. Oh, there we go. It's slow to advance here. So we've shown this before, maybe not this specific way though, that the main finding from this study is that the short-term changes in plasma levels upon treatment are very predictive of long-term outcome. And here we're just graphing the change in the variant allele frequency, specifically for EGFR, for all patients where we have both the baseline and the cycle 3. So this is, the cycle 3 is just two cycles, about 8 weeks after initiation of treatment. The ones that are labeled blue here are the ones that go down to undetectable, scored as 0. And the ones that are labeled red, you can see those have some sort of residual ctDNA levels at cycle 3. And then the patients, if it will advance, these figures must be very big. So when it comes up, there we go. Oops. This is what happens at progression. Here we graph the progression in real time. So those are months you're looking along the bottom. You can clearly see the ones that had residuals, the red ones, progress very quickly compared to the blue ones, which are the ones that went to 0. And we'll see that by Kaplan-Meier in just a second. But here you can see, you know, in some cases at progression, we see detection of EGFR. And in a number of cases, we don't see it. It remains at 0 or low. But you can see how quickly those red ones are coming up. And so by Kaplan-Meier analysis, if you are showing ctDNA clearance at cycle 3, day 1, you're having a dramatically improved progression-free survival against those who have residual ctDNA with a p-value of 0.0001 and a very low hazard ratio. And this remains significant for overall survival Again, if you clear, you do much better than those that don't. One thing that we found very interesting, and I was keen to do this analysis, is to ask the question, how much more predictive is the plasma analysis compared to RECIST? So we graphed out just patients based on RECIST response. On the left there, you're seeing progression-free survival based on whether they had a response or not. And in terms of progression-free survival, it interestingly didn't seem to make any difference. They did about the same. By overall survival, those that were responders do a little, do significantly or almost significantly trend to better. But in no way is the actual RECIST data, your first scan, anywhere as predictive as the plasma was in this particular study. Another interesting finding is we worked with Garden to do a more formal plasma molecular response. And that is essentially a consensus response of not just EGFR, but all of the variant allele that are detected in those patients. And so it's a little different from what I just showed you in that we were only looking at EGFR just as a single variant and tracking that. The plasma response score is looking at all of the mutations that may be present in those tumors, P53 and other things like that. And in theory, that would add more power, but it actually, while significant for progression-free survival, not quite significant for overall survival, it does show what we expect to see. But in many cases, it actually seems to obscure some of the data. And without going into a lot of detail about it, the reason for this is that there's a fair amount of CHIP. There's a fair amount of non-tumor ctDNA involved here and detected both at baseline and on treatment. And that throws off the analysis because it doesn't change upon treatment. So by way of overall conclusion, clearly we're seeing that treatment-induced changes in ctDNA kinetics in those first few weeks, those first few cycles of therapy are highly predictive of long-term outcome. This has also been seen in immunotherapy and chemotherapy as well, at least in our study, and it's been reported at least in one other study that is actually more predictive than RECIST response. If you're looking at targeted therapies, you may be better actually just tracking the main driver mutation, EGFR, ALK, what have you, as opposed to doing a molecular response score. But in immuno-oncology, a plasma molecular response score is going to be necessary because you can't count on the patients having an individual driver, and it gives you more data. So what are the therapeutic implications of this? We really need to focus on studies that can effectively identify and match innate resistance. Clearly, there's a set of patients that just aren't getting that benefit out of targeted therapies. And while we all know that, there's nothing that we really have been doing about it. We may be able to detect theoretical resistance mechanisms, and we saw a number of them in this study, but we don't act on those because we're optimistic that the patients will get a full response. But now that we have ways to actually interpret more accurately whether a patient is going to have a decent response, namely plasma kinetics, I think it's time that we start looking into how we can effectively manage upfront innate resistance mechanisms. And that can be done either through changing the type of drug or augmenting therapy. And with that, I will stop and take any questions if there are any. And return the screen back to you, Karen.
Thank you. See if I can turn this screen back. So do you all see my screen now?
Yeah.
Okay. So I'm not seeing any questions at the moment. Thank you. I think that's very interesting, and I agree completely. We do need to really interrogate these findings further in prospective trials. Thanks again. All right, now we're going to move on to our community engagement subcommittee and a presentation by Dr. Hesketh.
Thanks, Karen. Hello, everybody. So we have the next slide, please. So the Community Engagement Subcommittee has remained very active, and we have a very dedicated group of members. And we've recently been joined by a new person from the Ops Office, Maria Norman, who will be supplying logistical support for the group. Next slide. So within the last year, we've also kind of extended the reach of the Community Engagement Subcommittee by soliciting really another group that's working in concert with us, the Community Oncology Support Group. And this really is a group that we hope and is in fact working in collaboration with our subcommittee to try to better engage community oncologists and trying to basically advance the mission of the SWOG Lung Committee. And I think there's a number of ways that we've been trying to utilize this group. We're trying to use them to obtain input on new study concepts, basically provide that group with a focused update when we open a new study, and then basically have them hopefully become community-based champions for those trials. We also will use them and have used them to try to obtain feedback on trials that are having accrual challenges. And we plan to try to provide this group with focused updates on active clinical trials to give them a status update to hopefully maintain enthusiasm. Next slide, please. So again, our charge from Karen is to try to enhance our committee's mission by really trying to engage better our community-based oncologists. And we have a number of responsibilities. We've been involved in the clinical trial development process. We review trial designs to try to make sure that they're consistent with community expectations as well, in addition to the scientific questions. We try to identify potential barriers up front before we embark on the trial. We then try to be champions in the community network. We have very engaged monthly calls. And hopefully, Karen, at some point, we'll have in-person meetings again. Hopefully the next time in Seattle, because those tend to be really nice meetings. And once the trials are open, we're also participating in accrual enhancement efforts. Next slide, please. So ongoing activities clearly include our involvement in protocol development. And again, at every stage, we try to get involved from the time of submission to triage to CTEP submission, protocol development when the trials are activated. And then once the trials are actually active, we hopefully can have a role in terms of enhancing accrual. And again, we're working in active collaboration with our new lung community oncology support group. And I think one of our most recent initiatives, which we're very excited about, is our outreach to Encore sites in partnership with the MedNet. Next slide, please. So this has been a very interesting activity, which we're very excited about. And basically, this is a partnership of our subcommittee with the MedNet. The primary leaders of this effort have been Jeremy Kilburn, who's one of our subcommittee members, Nadine Husri, and also more recently, Liza Henry, who's also been working as a representative from the MedNet in helping us with this initiative. Next slide. So those who don't know about it, the MedNet's a very interesting digital platform in which clinical questions that are really quite topical are presented. It's really a forum in which questions can be presented and then can really be commented on by oncologists from across the country. And it really has a growing membership now. It's in excess of 13,000 oncologists. And I suspect many of the folks in this audience today are probably involved with the MedNet. It includes folks from a variety of different settings, and many academic oncologists have been involved. And it really is an opportunity to try to highlight key publications, trials, and expert opinions. And again, the number of usage so far has exceeded a couple of million. Next slide. So what we're trying to do is to basically use this tool as a means to educate and reach out to our community-based oncologists. And really, our primary focus initially is trying to raise awareness of two critical trials, SWOG 1827 and SWOG 1914. And basically what we've been doing is extending invitations to SWOG members via the Encore mechanism to join in the MedNet, and then basically deliver some targeted newsletters. And then basically, as you'll see, have a trial relevant question and answer session. And then we will ask the study PI to respond to the posed question. We can then get real world input in terms of polling the folks that are going on to look at this. And we can provide links to clinicaltrials.gov to give them more trial information. Next slide, please. So again, this is how the MedNet homepage looks like. And as you can see, we've recently just, again, put up Chad's trial. And so you can see here in the middle, we have the fact that it's labeled as a SWOG clinical trial. We have a question posed: how do you incorporate PCI into your management of patients with extensive stage small cell lung cancer? And then Chad basically responds to that with really a very, very thoughtful and elegant discussion about that, which the folks can take a look at. And clearly, the individual is identified as the PI for this trial, and the trial is highlighted in the discussion that the folks see. Next slide. We're very excited that this has now gone live, Karen. And so we basically have our first week of activity was beginning in October. And you can see that a lot of uptake with over 800 individual med and rad oncs viewing this. And basically they're looking at what Chad is saying. It's a variety of settings, both academic and community-based, a lot of different institutions. And you can see by the engagement that over 250 individuals responded to the question by showing what they would recommend in terms of PI usage in extensive stage small cell. So we're very optimistic and hopeful that this will be an interesting mechanism. And we're very grateful to the MedNet in partnering with us to really highlight, key clinical trials and just try to get more awareness out there, more enthusiasm, and ultimately more engagement. Next slide. Thanks, everybody. Happy to take any questions.
Thanks, Paul. And again, I just want to reiterate my huge thanks for this committee. I think it's been truly valuable. You are always, you and your committee, very engaged, looking at innovative ways, as we just saw. So really appreciate all of you. Thanks again. Don't see any questions at the moment. Okay. So we are on the home stretch here with the final set of presentations. And we're going to start off with a scientific presentation from Dr. Raymond Ozaro-Jabon. I'm not sure if I botched that, but I'm trying, Ray. So anyway, overcoming disparities across the spectrum of thoracic oncology. And I'm going to let Ray share his slides. So I'm going to stop sharing. And Ray, I hope that you can now share your slides.
Thank you, Karen. Can you hear me?
Yes.
Excellent. Well, thank you. So thanks for the invitation to talk today. I'm going to share with you some of the work that we have been doing within my research team in a large population lab that spans counties across 6 states. And the emphasis here is overcoming disparities across the spectrum of thoracic oncology. And I'm going to give 2 specific examples from an ongoing institutionally funded project we call the Mid-South Miracle. So these are my disclosures, nothing terribly pertinent to what I'm talking about today. My objectives are to kind of array out the geography of lung cancer in the United States and position my healthcare system within that geography, and then talk about our population-focused approach to improving lung cancer outcomes in a highly needy, challenging region of the United States using programmatic approaches, implementation science, team science, and population science in a project we call the Mid-South Miracle, and then give you two examples. One with early detection, another about what we talked about earlier, a topic near and dear to my heart, multidisciplinary decision-making. So lung cancer in America, a tale of geographic disparity. You see the deep red states. These are the states at the very top of the per capita incidence and mortality leaderboard of America when it comes to lung cancer. Kentucky #1, Mississippi #2, Arkansas #3, Tennessee #4, West Virginia #5, and so on. No surprise why this geographic pattern exists. This is also the smoking map of America. Now, we have been excited to know that in aggregate, US lung cancer incidence and mortality rates have been coming down sequentially for men for almost 2 decades, for women somewhat less. The story, though, is much more complicated when you break it down to the county level, at which you find that the story is much more heterogeneous. So yes, indeed, the green counties are the ones in which there has been the steepest decline in lung cancer incidence and mortality. But the pink, red, and purple counties are the places in which lung cancer incidence per capita is still going up, not down. And within that blue circle is the region, the catchment area of my healthcare system, the Baptist Memorial Healthcare Corporation. Now, if BMHCC was a state, we would have annually, with 1,200 to 1,300 lung cancer cases, we would have more lung cancer cases each year than 12 of the 50 United States of America. And within this region, which is mostly centered in Western Tennessee, pretty much all of Mississippi, Eastern Arkansas, but with counties that also spill over into parts of Southwest Kentucky, the Missouri Boot Hill, and part of Northwest Alabama, we find that there are certain characteristics. The heavily African-American counties, a lot of them very rural, really fragmented healthcare delivery, and so on. 44% of our 111 catchment area counties across the 6 states are what we call Delta Regional Authority counties. These are counties that are congressionally identified, just like the Appalachian Regional County Authority, as socioeconomically, the most socioeconomically challenged in the United States. So how does one go about tackling a wicked challenge like lung cancer at such a population level? Well, the answer is we have to be organized about doing this and look at where we might get the biggest return for our investment. And this is an outline of such an analysis, where by far and away, the biggest bang for your buck will come from tobacco control. The next biggest in lung cancer is to detect early. We know screening saves lives, but one of the things I will show you today is that there are other ways to detect lung cancer early, which we can all implement if we choose to. And then, of course, there's the optimal selection of treatment. And for those who have curative intent treatment available to them, ensuring they get to surgery and get that surgery done right. There are components of this that have to do with how well the pathology examination is done, including, of course, biomarker testing, which is a big and bigger part of the challenge that we grapple with every day. And then, of course, access to tomorrow's treatment today, optimizing systemic therapy, providing clinical trials access to a population that traditionally had been completely locked out of it. So early detection. This is the same map I showed you, except it's black, white, and gray. At the heart of it, the black colored ones are the ones with the highest per capita incidence and mortality from lung cancer. We know screening saves lives. We know that screening programs have been deployed across the United States. But what you see here is a mismatch between the places where lung cancer is the biggest public health challenge and the places where we have deployed LDCT screening facilities. So those dark black states, you don't really see a lot of round blue dots in them. And of course, we know that there's a general under implementation and under access of screening eligible individuals to screening. Kentucky happens to be an outlier. It's #1 on the leaderboard and has managed to figure out a way to expand access to LDCT screening. But you see the cluster of the numbers 2, 3, 4, 5, 6 all the way down are down within that blue circle, including the states within my catchment area: Tennessee, Mississippi, Arkansas, and bits and pieces of Missouri and so on. But so that's one problem, deploying LDCT screening facilities. But there's another problem that we're increasingly recognizing, which is that our screening eligibility criteria are not actually quite right. So based on smoking history and age, we determine who even qualifies for screening. Now, if you look at lung cancer incidence and the likelihood of being eligible for screening and apportion it according to race and gender, and create this thing called the EI ratio, the per capita eligibility ratio divided by the per capita lung cancer mortality, you find that we have basically baked in disparities into eligibility for lung cancer screening. So the higher the bar, the better the deal. Now, here are 4 clusters by race. White males in red, in blue, black males, in gray, Hispanic males, and in orange, Asian males. Looking at 5 different screening eligibility criteria, including the new U.S. Preventive Services Task Force criteria that expands down to age 50 and down to smoking intensity of 20 pack year history, which is the second quartet of bars. You see the pattern is essentially the same. White males by far and away the best deal, black males not so good a deal, and Asian males also get a really raw deal with some of the criteria. We also see the same pattern with women, with the addition that actually race for race, women get an even worse deal than men do in terms of eligibility for screening. So if we have this problem, we don't deploy our resources quite to match up with where the problem is, and we don't really know how to find the right patient who's truly at risk. No surprise, we have struggled in getting people screened, and potentially the impact of screening could be diluted. Is there something else one could do? Well, one approach we have taken is, while we are expanding access to screening, we know we do a lot of radiologic studies. And oftentimes these studies reveal the presence of a lesion that may or may not be malignant. Those lesions, there are guidelines to follow them, which oftentimes are not followed. So this idea of an incidentally detected lung nodule, we started an organized program that used the Fleishman Society guidelines to manage such patients. So what I show you here is 3 different programs. In light green, the incidental lung nodule program. In blue, the low-dose screening CT program. In black, for control, our multidisciplinary thoracic oncology program patients who did not go through either early detection program. And this just shows you that for every 1 patient we have got into the screening program, there have been approximately 3 patients within the lung nodule program. And then the second shows you the cumulative number of persons diagnosed with lung cancer. Again, blue is LDCT screening, light green, incidental lung nodule. And the relationship here is now 1 to 5. For every 1 lung cancer patient we have found through screening, we have found 5 patients through the nodule program. And this plot just shows you patients with stage 1 and 2 lung cancers, the people we really want to find, people who potentially have cure available to them. And again, you see the cumulative number of such patients, way more found through the nodule program than through the screening program. Now, the purpose, of course, of early detection is to find early lung cancers. And what I show you here is that proportionately within these programs, there is similarity in the distribution, the stage 1 and 2 distribution between the blue and the green, the LDCT screening and the lung nodule programs, about 60%. Now, in terms of the absolute numbers, not proportion now, but of all the patients diagnosed with lung cancer, you see how the lung nodule program actually significantly outperforms the screening program in terms of the sheer number of persons found with stage 1 and 2 lung cancers. Now, the point of finding early is to be able to offer a curative treatment. And once again, when we look at the proportions of patients who undergo surgical resection, whether by itself, which is the first triplet of bars, or any surgery, including neoadjuvant and adjuvant therapy, or surgery plus SBRT, which is the third triplet of bars, you find that proportionately, the 2 early detection programs do really, really competitively well. But in terms of the sheer raw numbers, once again, you see the pattern that emerges. You get a lot more bang for your buck doing this second harvest, collecting, images of people who had a scan for whatever reason. And then when it shows a lesion, putting a program around to make sure they get triaged accordingly. And here you see a survival plot where, yes, indeed, the screened patients have the best survival, but the nodule patients are also very competitive and better than the garden variety people who came in through our multidisciplinary program. So very excited to show that you can do this. And not only can you do this, but the demographic distribution of patients within the programs is very different. So I remind you that NLST had 4.5% of enrollees as African American. Now, because of where we are, 16% of our screened patients happen to be Black. But in the nodule program, it's actually significantly higher proportion. Also, ostensibly low-risk patients, such as people who would never currently qualify for screening, people who are never smokers. Almost 13% of the lung cancer patients in our lung nodule program are such patients. Of course, none such in the nodule program. And if you look at the median duration of people who have quit smoking, also quitters in the nodule program, almost half of them would not currently qualify for screening. So the point is, these 2 programs are synergistic. One way to get to early detection, even when there are barriers to deploying screening. Now, you find all those patients, what are you going to do with them? The goal, of course, is to be able to take them to surgery. But how often do we actually succeed in doing that? This is an analysis of US national data ordered by states, where we looked at the proportion of patients who had clinical stage 1 and 2 lung cancer who actually underwent surgical resection. You see the heterogeneity as low as 50% in Wyoming and almost 90% in Massachusetts, New Jersey, and Utah. Well, bad as that looks, at the county level, it's even worse. The amplitude of variation is as low as 13% and as high as 92%. What's going on? Well, when we looked closely within a large healthcare system arrayed across multiple states, looking at stage 1 and 2 lung cancer patients, you find this very interesting difference across 5 different programs. So stage 1 and 2 lung cancers, you ask the question, what proportion had surgery? That's the blue component of the composite bars at the bottom. And you see how it varies from as low as about 20-something% in hospital 4 to as high as 60-something% in hospital 1. What is equally disturbing, the red part of the bars, radiation therapy for stage 1 and 2 lung cancer, about 60, almost 70% in hospital 4, and most disturbing, no treatment for stage 1 and 2 lung cancers, as much as 40% in hospital 3. Why does this happen? Well, lung cancer is complicated. We know it's a difficult place to get to. The patients are older, they're frail, they tend to have multiple comorbidities from age and tobacco. Our array of options for diagnosis, staging, treatment, and subsequent evaluation continue to expand, which is the good news. Each approach is typically controlled by a different type of specialists. And unfortunately, oftentimes these specialists don't communicate effectively. So our care delivery infrastructure is fragmented. The solution to this appears obvious: multidisciplinary decision-making. So what is multidisciplinary care? Our favorite definition is the delivery of care by a coordinated team committed to processes that enhance certain group behaviors, which traditionally are believed to be necessary for high-quality outcomes. So we have taken away that belief and tried to impose rigor on it to demonstrate what multidisciplinary care is and what it might give to you in a sequence of studies that we have done with funding from the Patient-Centered Outcomes Research Institute and also from the NIH. And what we have shown is, for example, 3 different loci of care. One in our multidisciplinary thoracic oncology program, 2 in our metropolitan healthcare system, but not within the multi-D program, and 3 in our far-flung regional healthcare system. And here we see that the delivery of guideline concordant treatment is significantly more likely within the multidisciplinary care delivery forum, even compared to the metropolitan part of the same healthcare system with the same infrastructure, the same clinicians, and everything else. And of course, most disturbing, the proportion of patients who receive no treatment, significantly different. And therefore, no surprise, multidisciplinary, patients who receive multidisciplinary care, the green line at the top, had significantly better survival than the other 2 groups of patients. In blue, metropolitan non-multi-D patients, and red, regional non-multi-D patients. So this was one of the first published reports that demonstrated that multidisciplinary care is associated with a significant survival difference. So better mousetrap, better model. What proportion of patients within this healthcare system have enjoyed access to this program? Well, the depressing news is it's the minority. The good news, though, is that we are doing better. We're trying to increase the proportion. So why is this such a challenge? It seems obvious that multidisciplinary care gives you better outcomes. Patients love it. They're always surprised when we say we're studying how to do this. Isn't this what you already do? Why do you have to study it? The truth is, doctors hate it, okay? Especially community level practitioners who are much more entrepreneurial and used to functioning independently. And of course, part of the problem has been the paucity of data, either to define what multidisciplinary care is, or even in the past to show its true value. Therefore, hospital administrators and executives of third-party payers have had their own skepticism about whether or not that is, a preferred model. So we have done a lot of team science research trying to demonstrate, how to do this, including looking at shared mental models, mutual trust, mutual performance monitoring, backup behavior, and so on and so forth. And the challenge then becomes, how do you codify this? How do you benchmark it? How do you measure it? And how do you use it for PDSA cycles to continue to grind forward? This is work that we have done, and I just wanted to share with you today, and certainly wanted to be sure that I gave credit to the people to whom it is truly due, which is the people who have actually done the work. Thank you.
So Ray, that was an outstanding talk and really very provocative. And I think really raises the questions that you brought up on and how we as SWOG can be helpful here as well. So I think there's a lot that needs to be done here because we have to impact lung cancer. We got to get to all these communities. So let me again I don't know, Ray, if there are questions in the chat that you can see why I switch on back over to the other screen. You may take some questions here if there are any. I have a question at some point, but I'm gonna.
Don't see any questions just yet.
So let me ask my question on your nodule program. So you're taking patients who have had an incidental nodule found on a CT scan, correct?
Yes.
Yes. And my question for you is what do you then do with these patients in terms of you see them and their follow-up? Because what I find here in California, and of course we have a much higher number of never smokers who have CT scans for other reasons, and they don't qualify for screening. So what do you do with those patients that come to you in this nodule clinic? Do you order scans anyway, or how do you follow those patients?
Yeah, so we use the Fleischner Society's guidelines to manage them. So the interesting thing here is these patients, they come from many different reasons, right? Some of them, a lot of them have gone to the ER, they went in
Right.
belly pain, car accident, whatever, chest pain. They get a scan, typically, appendicitis, we're excited, we take you to OR, take out your appendix, expect you to live happily ever after, forgetting that the radiologist mentioned there was a lesion that needed to be followed, which never gets followed. So the idea here was to be able to have an organized way with the radiologist keywords, nodule, lesion, mass, whatever. You can set that however you want. We actually have Epic, our EHR, put such reports into a queue, and then we have a group of navigators come in every day and sort through the queue with the Fleischner Society guidelines on one hand. And then they triage the patients up and down into risk categories. The ones that are deemed sufficiently high risk, we then do the subsequent guideline recommended follow-up, whether it be an interval CT scan or, for those who hadn't had a chest CT scan, maybe a CAT scan of their whole chest, or an invasive procedure. We actually have a clinic run by interventional pulmonary and thoracic surgeon where those patients at highest risk for whom an invasive procedure might be recommended can be seen in clinic. And then all those patients are discussed in our multi-D conference, just to make sure that we're all in agreement with subsequent management. So the point here is it does away with all the barriers to screening. Your eligibility characteristics. Doesn't matter, there's a lesion. We start from that point. So we don't really care whether you smoked or not, there is a lesion. And then there's the issue of all the counseling that you have to do to encourage somebody to think about whether or not they want to be screened. Those you essentially do away with because there is a problem. It needs to be dealt with. And then the issue of insurance coverage, permission to do a test doesn't come up because there is a lesion. You need to do something about it. And what we're just ensuring is guideline concordant care.
So let me just follow up on that question in terms of what we find are these very tiny nodules to where no follow-up is recommended. So what's your denominator from this?
Well, nobody, if you have a lesion less than 4 millimeters, nobody really wants you to follow. So the Fleischner guideline sets the lower bar at 6 millimeters.
Right.
So for those less than 6 millimeters, unless the radiologist is jumping up and down telling us there are other features that make it super high risk, we would triage those patients into lower risk and not necessarily. So we discharge. So I showed you there are probably about 17,000 patients within the cohort in our nodule program that I showed data on just now. That represents about 30% of all the things that flow through. All the ones that get triaged out because, it's a granuloma. Come on, it's calcified. This is nothing. Go away. All those ones are not included. So the idea is to give evidence-based care that minimizes danger to innocent people, but optimizes, benefit for those who need that attention.
Okay, well, that's fascinating, as I said, because when we look at it, so many of them have these tiny nodules to where it's no follow-up needed, but then they'll say, but if they have high-risk features, and of course the radiologist doesn't know that, then that's the issue. And it sounds like you're still seeing these 4 mm nodule patients and then stratifying them, correct?
Yes.
So you're
Yes,
still
yes.
seeing all the non-calcified nodule, regardless of size, to see if they have these other high-risk features, and then you're stratifying them. Am I?
Exactly. That's what the
Okay.
navigators do. So they call,
Okay, wow.
they call the patients the first thing they do is they call the person who ordered the study, right?
Yeah.
Entrepreneurial primary care doctors and so on. They say, look, your patient was in the ER or wherever it was, had a lesion detected. Do you want us to help you follow it? Believe it or not, there are people who say, heck no, leave my patient alone, don't touch him, and we drop them. But everybody else, we would call the patient and say, look, you were in the ER, you had this thing, just tell us a little bit of information. Do you smoke? How much you do? So on and so forth. And then once all the variables are in, they use that to triage the patients into risk categories.
So Ray, that's
Go ahead,
Karen, if I could just make a comment.
Yes.
So Ray, that was a terrific presentation. And I think what you've really highlighted is the fact that there has to be a dedicated institutional commitment if this incidental nodule process is going to work. I mean, it really can't be done as an ad hoc, sort of regarding, relying on radiologists to maybe refer or having someone think what to do. You need to have a concerted program that has navigators that are supported by the institution, and then a consistent way that you're going to manage those, ideally in a incidental nodule clinic. And so I think what you've outlined is exactly what's needed. And as you can see, the yield from that population, even though we're very strong advocates for screening appropriate high-risk patients, the yield from that particular population is going to be even higher in terms of finding early stage lung cancer. So I think what you've said is incredibly important, and hopefully most institutions will sort of recognize the value of that. And when you do economic analyses, they're always leery of making new investments, but the economic positive side of finding those patients early, as you know, is extraordinary. And particularly as you get more and more systems where you're going to be responsible for a given population of patients with a fixed amount of money, I think you can make a more compelling case to your administrators to have such a program.
Yeah, absolutely, Paul. As you well know, these things are hard. So there's no altruism here. I want to be very transparent about that. But this is a hard-nosed business plan. The reason why my healthcare system has invested, tens of millions of dollars in deploying our so-called Mid-South Miracle Project is because there is money to be made. There is a huge return on this investment, and it's a quadruple win thing. The patients certainly win. My bottom line message to my C-suite administrators was, look, there is no billable encounter that comes from a dead person, okay? Think of this as an annuity model. You keep people alive. They live to come to enjoy your service another day. And that's just the bottom line.
Well, we all agree with you there. So I think we just need to take this data and see what else we can do in a more, collaborative way. I mean, you've done a great job at where you are, but these are issues across the whole United States. So NIH is very interested in this. We're actually putting together a clinical trials planning meeting that Mary Wood and I and Kim Sandler and Jacob Sams actually trying to work with the Cancer Prevention Steering Committee at NCI. So more to come. Thank you so much. All right, so we will now move on to just some updates that we have. So the first up here is Ann Chang on Insignia.
Oh, I'm first. Okay.
You're first.
Thank you. So this trial is, as you know, our collaborative piece of work, labor of love with ECOG, and we are doing better with accrual. We're about 43% accrued. That is 360 out of 846 trials and patients. And this is a frontline for PD-L1 positive, at least 1%. And it is randomizing to pembro alone in arm A, followed by chemo upon progression, pembro alone in arm B, followed by the addition of chemo to pembro, and then arm C, which is our control, is the Keynote 189 regimen. And if you go to the next slide. So I think, these are the questions that are really important. Can we spare the use of chemotherapy or delay it in PD-L1 positive patients? And if you recall, Mary Redmond's stellar performance discussing the FDA analysis at ASCO, we really need to answer this question with a prospective trial. And then secondly, does adding chemo to immunotherapy post-progression boost response? And I think this is also a key question that so many of us would really, have anecdotal cases, but really needs to be answered again in a prospective fashion. And then ultimately, can we develop a prognostic immunosignature for pembro response and a predictive signature for chemo with pembro? We've looked at some of the barriers to accrual, and we have tried to be very we've made some amendments to the protocol, but basically tissue, we're being very generous. So if you have tissue, we obviously want it for the translational piece, but if you don't have, you have to have some tissue, but if you don't have, the 10 slides or the 15 slides that we request, that's fine. Patients can still go on trial. I recently reviewed the eligibility again, just for a patient of mine, and if you have a patient with a pleural effusion, they can go on the trial. So you can have non-measurable disease. Obviously, we are looking for measurable disease, but if you have patients with pleural effusions, they can still go on trials. And then with the brain mets, patients can go on with asymptomatic brain mets, or they can be treated and stable as long as they're on prednisone 10 or lower. And we're looking for a study to show stability before they go on trial. Previously, we had indicated 4 weeks, but that can be less. That can be 2 weeks. So lots of things to make it a lot easier for patients to go on. It's an important question. SWOG has put 45 patients out on this trial out of the 360. So I know we can do better. There was a lot of talk prior to the trial in terms of the 1 to 49. Anecdotally, I've had patients who are in that category who've done really well on trials. So please think of this trial. It's really important. I think if we all can put a few patients on, we can finish it up and find out the answers to these really important questions. Thanks, Karen.
Yeah, thank you, Anne. And I just want to echo what Anne just said. This truly is a great study and is really asking important questions. So I think, again, we should just continue to screen your patients for this study. Okie doke. Right. Next up, Sarah, Dr. Goldberg.
Yes, hello. Hi, everyone. So I'll be really quick. I won't even give you the background because I think most of you know. Karen, maybe you could just skip ahead to the schema and I can just talk a bit about this study. Great. So I am here to be a champion for this trial. This is an ECOG trial, which we have opened through SWOG as well. It's a randomized trial for patients with EGFR mutant non-small cell lung cancer, where they're randomized to osimertinib alone, of course, the standard of care, or osimertinib plus bevacizumab with the standard dose every 3 weeks. This is a trial that's, the goal is to accrue 300 patients, and the primary endpoint is progression-free survival. The slides we just skipped over summarize some of the data that supports this, this combination of osimertinib and bevacizumab, and just to briefly summarize, I think we all know that the combination of EGFR inhibitors with VEGF inhibitors or VEGFR2 inhibitors have a long history where there's been fairly consistently demonstrated a progression-free survival benefit, but more difficult to show an OS benefit. There was a recent study, a much smaller Japanese study, where they looked at osimertinib with bevacizumab, and there didn't seem to be a benefit there, but that was in an entirely Asian population. And so this is a larger phase 3 study in a North American population. And so I think this still has an important question that we are looking to ask. We also are allowing untreated brain metastases, which is, as you all know, very common in our patients, and they don't require radiation before going on. So Karen, you can correct me if I'm wrong. I don't think there are other first-line EGFR trials right now through the cooperative groups. There are some that are in development for the future. Maybe we'll even talk about them here, but this is right now the only trial for EGFR positive lung cancer in the first line setting, asking an important question, and hopefully this will be the definitive answer on the use of bevacizumab in the first line setting. So I would encourage you all to open this trial. We are still working on opening it at Yale, but we are planning to do so. Karen, I think you have it at your site. Accrual has been slow nationally. And we really are looking for more sites and patients. So that's all I had to say. Thank you so much.
Thank you, Sarah. I do agree this is a good trial. Again, we are supportive of it. So I think if you have patients to go on, that would be great. There aren't any current trials. So please, again, put patients on so we can complete this. Again, completing it and then answering an important question. So that's the goal. All right, Dr. Herbst, the LungMap PI, you're up.
Hey, hi everyone. We had a big day of LungMap yesterday, but we're doing quite well, as you can see from the slide. We're open all over the country. We have crossed 4,000 patients. Thank you, everyone. It's really, the accrual of this trial has just been amazing. Screened at PD 1969. Pre-screen 2095. The current iteration LungMap, over 2,000 patients, 842 screened at progressive disease, and 1358 pre-screened. And then if you look down at sub-study registrations, that's the key. You can see we're almost at 1,000 sub-study registrations. So patients are actually on drug since we began this 7+ years ago. 690 on the 1400, 305 on the LungMap. The only reason we don't have more on LungMap is we need more sub-studies, but we're getting there. Next slide. And here you can see the current schema. And what you're looking at is S1400. That was a squamous only iteration. And now LungMap in green. You can see there's one LungMap sub-study open right now. Amgen 510. That's the KRAS G12C. But you also you just heard from Adam about the N803 plus pembrolizumab any day now. So there'll be 2, and there are so many more things in the hopper. And then on the left, you can see all the biomarker-driven studies, using the Foundation Medicine profiling. Most of those studies in blue are now published, and many of us are authors. And on the right, you can see the non-match sub-studies. Many of them are actually also published. Next slide. And here's some recently completed sub-studies. S1900C. This was a Pfizer study, a biomarker-driven study, LKB1, SDK11. Valerie liked this study so much she went and worked over for Pfizer now. We don't have the results of this yet, but accrual is completed. S1900A, that's Clovis, a PARP inhibitor for LOH high BRCA1 and 2 lung cancer, rucaparib. It closed 2-1. Unfortunately, it was closed for futility, but a very important question, hypothesis answered. Then there's S1800A, that's the Merck and Lilly collaboration. It's a non-match study of pembrolizumab and ramucirumab, PD-1 plus VEGF. That actually closed. It went all the way to the end, so it actually met its interim endpoint and went to the end, 11/16/20. Accrual is completed, and we're waiting for the call of the results. Hopefully, we'll have it for ASCO next year. And then S1900B, Loxo Lilly. This is a biomarker-driven study with RET fusions, Loxo 292. It opened. We accrued about 6 patients. The drug became approved. We're now combining with chemotherapy, so we're redesigning that, and that should be open again soon. Next slide, please.
Yeah, I just want to say that you're right. We're hoping to have both an abstract for ASCO on 1800A as well as 1900C. So we're excited about that. So.
And then we have a lot of papers here, 2 recent papers. Natasha, the durvalumab plus tremelimumab study, and then Scott Gettinger leading the nivolumab, ipilimumab versus nivolumab. This study, by the way, the samples are with the CMAC, which is one of the NCI consortia groups that are working on tissue biomarkers for immunotherapy, Mount Sinai and MD Anderson, Ignacio Estuba. So we're generating some interesting data that hopefully one of us can show you at one of our next meetings. So this has been a great effort, amazing community engagement. Minority accrual is high. I think we're going to see something from Suki in a second, but the number of patients that we've accrued to 510 already exceeded the number that went on by far in the randomized the codebreak trial that's published in the New England. So we are getting drugs to patients at their point of care, which is our goal. So thanks, Karen.
So I'm not sure Dr. Pata is on. I didn't see her a minute ago, Roy.
She's not on.
Yeah, she is clinic
today.
Right. She said she was going to try to make it. So do you mind, Roy, just kind of taking us through this a little bit?
Sure. First of all, Suki and David Gerber are our PIs. They've been wonderful to work with. By the way, this started out, through the ECOG, actually, taking the lead. Suki just happened to have made a good career choice and moved to a SWOG institution. But it's been a partnership, and S1900E, Amgen 510, sotorasib, in patients with G12C mutated lung cancer. Next slide. This has sort of been the biggest story. I guess now we have some adjuvant therapies too, but this is a pretty big story of the last year. The response rates of almost 40%, disease control of 80% in KRAS G12C refractory patients with a median progression-free survival over 6 months, 6.8 months. This drug is clearly a second line answer to the question, can it be better if it's looked at in groups with certain co-mutations? If we find those co-mutations, could we even think about taking it to the frontline setting someday? Next slide, please. So here you can see the co-occurrence of molecular alterations is frequent. So you can see that there's been a lot of work by many on this call, the STK11 and KEAP1, and you can see objective response rates appear to be much higher in patients. If you look at KEAP1 wild type, 44% versus KEAP1 mutant, 20%. And if you look at the right, you can see overall response rate by co-occurring mutations in both STK11 and KEAP1. So the highest response rate is in STK11 mutant and KEAP1 wild type, and the lowest response rate is in STK11 wild type, KEAP1 mutant. But these are all small numbers. So what the lung map can do for us is it can find us these patients biomarker driven and increase the precision. Those error bars will not be so large if we had more patients. Can we see how STK11 and KEAP1? So here's the trial. Karen's moving me along. S1900E substudy, recurrent or metastatic KRAS G12C, received at least 1 prior systemic therapy, no uncontrolled brain metastases, but you can have them. They just have to be controlled. And look, there are 3 groups. There's KRAS G12C TP53 mutant, 40 patients, KRAS G12C STK11 mutant, target 25 patients, and KRAS G12C and any other mutations target 40 patients. And then you can see the dose of the drug. They're all getting the same dose of drug, and we're looking at objective response rate as our primary endpoint, and secondary endpoint duration of response, progression-free survival, and overall survival. Next slide. I think there's just 1 or 2 more. Screen early. So screen often, screen early. Okay, next. And this is what Suki put this in. See, I didn't make her slide, so I didn't know she had this. Apologize. So only 2 Black patients enrolled in CodeBreak 100, but given lung map screening protocol, higher likelihood to enroll diverse populations. And you can see already in the lung map, the number of patients, the Hispanic patients we have, and Black patients and Asian patients. And it's only 27 patients so far in S1900E, but we're already getting patients of diverse ethnic groups, and we'll get many more. And that really is, when we started this many years ago with the NCI and Janet Woodcock and Ellen Siegel, the idea was we're going to get drugs to point of care to patients, and we're, I think, perfectly poised for this right now. Next slide. I think this might be the last one.
Yes, this is the last one.
But we're excited about, we need your proposals. Anyone, if you got a student, a fellow, junior faculty, if you're a senior faculty with a good idea, please bring it to us, and we'll try to get it into the lung map.
Yes, and I do want to just point out that this really is an important trial. Even though the drug's approved, trying to figure out who responds, who doesn't respond is critical. I think you're seeing this theme across the day today. That is so important so that we can augment therapies if needed to, and then those that don't need it, we don't do that to. So just this is, I think, really, really important, as well as to, really understand the biology here and then be able to leverage the biology. So with that, I'm just going to go to the next slide. And this is, Roy, you've already talked about this. This is the revision of the RET trial. Dr. Elamine and Dr. Gray are the chair and the co-chair. I don't believe either one of them are on, but you've already talked about it to where we're now looking at the combination of selpercatinib with chemotherapy versus chemotherapy alone. I think here again, this is going to be a really good trial as well. So just FYI on that. And now we have one more. And Dr. Mazzarelli is here as the study champion of this trial, which is an ECOG study.
Yes, hi, nice to see you, all of you. So this is a phase 2 trial, EA5191, with cabozantinib versus cabozantinib nivolumab versus chemotherapy for non-small cell lung cancer. So stage 4 non-squamous histology or recurrent earlier stage of disease, with a progression on one line of platinum-based chemotherapy and only one line of anti-PD-1 or PD-L1 checkpoint inhibitor, either in combination or sequentially, are eligible for this trial. So there will be stratification by duration of prior immunotherapy. So 6 months is the cutoff. Intended chemotherapy, so ramucirumab or non-ramucirumab, they will be randomized to arm A, cabozantinib alone, which is, and then arm B, which is cabozantinib plus nivolumab, and then arm C, which is a standard of care chemotherapy, either docetaxel plus or minus ramucirumab, gemcitabine, nab-paclitaxel. And actually, there is a new amendment that is coming up and will be approved in January 2022, where basically there has been the removal of targeted cohort T and stratification for prior targeted therapy for ROS1, RET, MET, and simplification of eligibility criteria, and many other clarifications. So as of now, there are 23 patients enrolled up to October 13, and 22 were on randomized arm. So this is an interesting trial. I know, I mean, we didn't have the non-match arm for lung map, but I think, it's coming up. So hopefully we can get some patients randomized, enrolled in this trial. Thank you.
Yeah, this is a good trial. So hopefully, to your point, that we can get some more patients on there. All right, now we're going to move to small cell lung cancer. Dr. Kareem, is she still on? Or maybe she,
thank you so much.
We can't hear you. Nagla, we can't hear you.
Is the maintenance study? Hear me better?
Not really.
Hello? Not really. Oh, okay. Is it better this way?
I can barely hear you. I don't know whether others can hear you.
I don't know whether others. Is it better this way?
Why don't you go ahead? It's really soft, but go ahead.
Okay. Go ahead. Yeah. So this is the maintenance study. Basically, we start our patients on conventional, the carboplatin etoposide, and then they can be screened for Schlafen-11. If it's positive, then they are basically going into the eligibility criteria for that study for Schlafen-11. directed maintenance therapy. So it will be carboplatin, etoposide, and atezo to continue 2 to 4 cycles in the induction. Then in the randomization, they can be randomized into either the maintenance standard of care atezo versus atezo plus talazoparib, which is the PARP inhibitor. Main hypothesis is that SLFN11 positive patients will do better once treated with a PARP inhibitor. Next. Next. Dr. Kelly, can you hear me? It's next.
Yeah, yes, I've advanced
So,
slides.
yeah, sure. Sorry. Sorry. So basically, we did well. Our screening goal 323 and our randomization goal 94 to be able to enroll 84 eligible patients. We did to date screen 147 patients, and basically we were able to have 40 patients randomized into arm B of the study. SLFN11 negative patients were 30 and the positive patients were 90, which tells us that we have more SLFN11 positive patients than we thought it would be 50%, but it seems that we are doing better. We have basically 4 days as a median turnaround time for knowing the results. Next. So I just mentioned that we are now validating the SLFN11 in FNA, fine needle aspiration. Still not there yet, but I think hopefully that can be something in the future. So questions?
Thanks, Dr. Kareem. Thanks, Dr. Kareem.
Thank you so much.
All right, so I just, 1 second on Ann Sal's trial. She could not be here today as 1701. Just please remember this study. We actually have increased accrual on this study. This is a good trial as well. We put patients on this. I know that it's a rare tumor, but please, if you have those patients, put them on because as I said, this really is a good trial and patients are doing well on the ramucirumab component in terms of, tolerating it. So just an FYI, please do not forget about this study. And then our last presentation, Dr. Genturo will present on her study. You heard about this last time, but she wanted to give us an update. So thank you all for staying and hearing this short presentation.
Thank you very much, Dr. Kelly, and running lung committee marathon. We can go to the next slide. On behalf of S2013 team, this is a iCheckIt study, prospective observational study. Primary objective is to develop and validate a risk prediction model for CTCAE grade 3 or higher non-hematological IRAEs for patients who are getting ICI, immune checkpoint inhibitor therapy for their treatment of solid tumors. We can go to the next slide. So the secondary objectives are mostly also focused in addition to higher grade toxicities, the low grade toxicities, and what is the burden of these chronic grade 1 and 2 toxicities on our patients, along with knowing what the patient reported outcomes are, including quality of life and adverse events. Next slide, please. So any solid tumor patients receiving ICI alone or in combination with another ICI or FDA or NCCN category 1 or 2A are eligible for this study. They cannot go on another treatment trial participation during this trial, and they're not able to get chemotherapy, biologic therapy, or targeted therapy in combination with ICI. So for say example, if someone is getting carboplatin, pemetrexed, pembro, and then later they go on to pembro alone, they would not be eligible for this trial. Next slide, please. So our goal is 2,062 patients, which translates to 57 participants per month. And we're proactively planning for diversity and inclusion by engaging our Encore sites and SWOG's Latin American initiative, along with our Canadian sites. We also have PROs in Spanish and French. Next slide, please. So this is the study calendar. We can go to the next one. So at the pre-registration, they will get standard labs and treatment per the treating oncologist, and we get information on their history, physical performance, concomitant medications, along with the CTCAE. At this time, patients also do fill the patient-reported outcomes, and they get blood work as usual per standard of care. Next slide, please. In addition to the first baseline pre-registration, there are also 4 other time points at week 4, 12, 24, and 52, where we get information about concomitant medications. We get data on CTCAE, PROs, and they get the standard labs. Blood is drawn at baseline prior to starting ICI for the biorepository. And then at week 4, mainly, if someone develops grade 3 or higher toxicities, then they would also get blood at that time. Main thing is, in between these time points, site still needs to assist the CTCAEs to know when these IRAEs are developing to report at the next time point. Next slide, please. So these are the patient-reported outcomes. We can go to the next slide in the interest of time. So translational objectives are, one is cytox score, which is 11 different cytokine composite measure. And next one is to establish a repository of archival tissue and blood specimens for the predictive or prognostic markers. If they have archival tissue from before, we will request that. If they don't have a biopsy, they do not have to undergo another biopsy. Next slide, please. So this is the simple schema. Once they consent and register, they undergo evaluation, and they undergo evaluation at these 5 time points and at the development of grade 3 or higher toxicities. And that finishes the trial for 52 weeks. Next slide, please. So this is for across any solid tumors, and we have a lot of patients in our clinic who are not eligible for clinical trial, and this would be a great trial. And we'd like to welcome and open this trial at your institution because it's easy and not complicated. One more thing I would like to thank is to Dr. Nagla Karim, who worked on with the digital engagement to develop this social media toolkit for this study with iCheckIt hashtag in Twitter. Next one, please. I think we're done. Thank you very much for everyone, and hope you can open the study and enroll the patients. Thank you, Dr. Kelly.
Dr. Kudera, did you want to say anything?
Oh, thank you so much. I kind of put it in the text. Krishna is she's our fearless. We made her our PI of this great team effort. We really appreciate, Dr. Lyman and I were the team that helped Dr. Khurana develop the Khurana score. We had a large cohort study prospectively developed for febrile neutropenia and also had venous thromboembolism. So large real-world cohort studies can be key to find and validate the key risk factors, risk stratify, and that enabled then the New England Journal companion prevention trials. And we want to do the same here with IREs. And thank you for helping Krishna and us and this great team to make this happen. We really appreciate it.
I just have to say that you know you have a great team when everybody is still on at the end of 3 hours. So I have to applaud. I'm seeing everybody still on. I do have to applaud everyone for staying on because this is such an exciting time. We do go to, every time I do this, I keep thinking maybe I could get it a little shorter so that we don't go quite to the very end. But we always do, and we went just about 5 minutes over, but I so appreciate everybody staying on. As I said, that's a true sign of having just a great team, and SWOG is great, the lung committee is great. So with that though, I have to say, it's hard to do this on Zoom when there's so many people and slides and chats and everything. So thank you for your patience with my earlier technical difficulties. Thank you. Cannot wait to see everybody in person in Seattle, not San Francisco, Seattle. It's Seattle in April, which will be a beautiful time there as well. Mary's going to guarantee us that beautiful time in Seattle, the beautiful weather, all right? So take care, enjoy, and happy holidays.
Thank you.
Thanks,
you.
Karen. Goodbye.
Bye.
Thanks, Karen.
Bye-bye. Thank you all so much again, really, for staying on. It's really helpful. It's important, so appreciate it.
Thank you, and apologize for the voice.
It happens to all of us. I think you had 2 things on or something. We were